Just keep talking amongst yourselves. We'll go on with the hearing. The agenda is rather full, and the time is sort of allotted for an hour and 15 minutes for those speaking in connection with the nurse practitioners. And so there are a number of people, but we're going to try to hold that to an hour and 15 minutes. But, you know, I can be flexible. Maybe the rest of you all were experts on nursing and nurse education and all before you were elected to the legislature. It was not one of my areas of expertise. But as all of us do, when we are named to a committee, we start trying to focus and learn. And so what I'm hoping to accomplish in the hearing today is for us to learn a bit about how one becomes a nurse practitioner, and then how one, what authority one has. I'm sure people can correct me if I'm wrong, but it helps me to think in these terms. There's sort of two things going on at the same time. There's sort of the world of education, where you go to school and get degrees, and eventually you can get a doctor of nursing. There's also a world over here in which people are licensed to practice nursing. And just as you can get a law degree and never actually practice law, you could get a nursing degree and I guess never be a nurse, but that's really two separate things. There's the academic side and then the licensing side. In order to further confuse things, and I'm saying this right now, so if I've got this wrong, people who are speaking after me can correct me, that the Mississippi Institutions of Higher Learning, IHL, regulates academic instruction in the state of Mississippi at all levels. Meanwhile, the Board of Nursing is in charge of licensing. And with that brief introduction, I think Dr. Temple, you are first on the agenda. So if you'd like to help us, I'll recognize you and just make yourself at home. I will say this as a general rule. I think it'd be well to get the majority of the presentation over before we start having questions. But having said that, if there's something that's a brief question that you're confused about, didn't understand something, feel free to interrupt and we'll try to get that clarified. But as far as more detailed questions and all, I think it'd be better till we waited to the middle of Dr. Temple's presentation, except of course for me, because I'm the chairman and no rules apply to me. And I'm an only child.
Good afternoon. I'm Melissa Temple, and I'm the Director of Nursing Education at Mississippi Institutions of Higher Learning. I want to thank you. Can you hear me? Okay. I want to thank you for inviting me to come here and speak today about nursing education in Mississippi. I've been a nurse for 25 years, and I am proud to be a part of the nursing profession, especially during the COVID pandemic that's brought so much attention on nurses and the high level of knowledge and skills that they provide, that they've learned in their nursing education practicum. Nurses have been described time and time again as heroes during this COVID pandemic, not only for their dedication to their patients and their profession, but because of their ability to provide safe, competent, high-level, life-saving care in which their education and their training prepared them. You should have a handout of my presentation, and in that handout, I have 3 attachments that I will refer to. According to the Mississippi Code, the Board of Trustees for Mississippi Institutions of Higher Learning is empowered with the regulatory authority of Mississippi Registered Nursing Degree Programs and Higher. All schools of nursing in Mississippi are required to attain and maintain national nursing accreditation. IHL does not have program oversight of practical nursing programs in Mississippi. The Mississippi Board of Nursing is the state accrediting authority for practical nursing programs. IHL is the regulatory authority for all 23 registered nursing and higher schools of nursing in Mississippi, and this includes community colleges, public and private colleges and universities. The first attachment that you have is the Mississippi Schools of Nursing and Degree Programs, and it outlines the degree program options offered at each school of nursing. We have 17 associate degree, 8 baccalaureate, 6 masters, 5 Doctor of Nursing Practice, and 3 Doctor of Philosophy degree programs in Mississippi. Annually, a detailed annual report for Mississippi nursing degree programs is published in May, once approved by the IHL Board of Trustees. And the recent May 2021 annual report, as well as reports from previous years, can be accessed on the website. For the academic year 2019-2020, we had 2,757 graduates across all degree types. And in fall 2020, there were 5,937 students enrolled in schools of nursing in Mississippi. The detailed IHL state-specific requirements may be found in the Mississippi Nursing Degree Program's accreditation standards, also located on the website. IHL state-specific minimal requirements specify requirements for associate, baccalaureate, and graduate programs for nursing administrators, students, faculty, curriculum, and evaluation. There are additional criteria that are required by the institutions, and as well as the national nursing accreditation requirements. I was asked to describe the levels of nursing education, levels of nursing from an education standpoint. So I want to take you first through, if someone wants to become a registered nurse in the state of Mississippi, what is that process? And there are 2 nursing degree programs offered that, once successfully completed, the graduate is eligible to take the National Council licensure examination for registered nurses through the Mississippi Board of Nursing to become a registered nurse. And those 2 degree programs are the associate degree and the baccalaureate degree. And again, those are outlined on that attachment 1 that I have provided in that handout. Through IHL accreditation standards, applicants must meet criteria for admission requirements such as a grade point average, ACT, criminal history background check with fingerprinting. The institution also has admission criteria that will include successful completion of prerequisite courses for admission eligibility. Once the applicant is accepted into a registered nursing program, they will have to demonstrate competency of nursing knowledge and skills as they progress and prepare to graduate from the program. What curriculum and training must graduates successfully complete to graduate from a degree program preparing them for a career as a registered nurse? Students participate in educational experiences via instructional teaching, return demonstration, and skills lab settings, and they practice scenarios that simulate the clinical medical site setting, providing patient care, and they also attend clinical medical site care facilities with faculty members to provide direct patient care. Students must demonstrate competency of nursing knowledge and nursing skills, again, to progress and graduate from the program. While there is no standardized curriculum or prescribed number of clinical training hours, the purpose of the schools of nursing are to prepare graduates for entry-level registered nursing practice. Students graduating from a nursing degree program preparing them to become a registered nurse must take the National Licensure Examination for Registered Nurses, and this exam is evaluated and reviewed every 3 years for currency, validity of content, and level of difficulty. Passing the test demonstrates the graduate has been prepared to enter the nursing field as a registered nurse and safely practice nursing as a new nurse. Therefore, nursing program administrators and faculty utilize and implement national nursing professional guidelines, standards, and competencies implemented into that curriculum. Some of those curriculum concepts and competencies are listed in the table below, and they include patient safety, medication administration, legal and ethical concepts, pediatric content, maternal child content, legal, ethical, just to name a few. During skills lab, laboratory practice training, students practice skills in a skills lab setting equipped with mannequins, trainers, and hospital equipment with faculty supervision they must first demonstrate competency of their nursing skills in the lab setting before performing the skills during direct patient care experiences. Students in Mississippi spend an average of about 126 hours in the skills lab. In simulation training, schools of nursing are limited in the number of simulation hours that they may utilize as a replacement of direct patient care hours. And students in Mississippi spend an average of about 49 hours in simulated clinical experiences. Direct patient care training that takes place in medical sites that deliver health care. The student participates in direct patient care with faculty supervision. And students in Mississippi spend an average of 381 hours in associate degree programs and 516 hours in baccalaureate degree programs providing direct patient care. The passage of the National Council Licensure Examination for registered nurses is one quality indicator of a registered nursing program monitored by IHL Nursing Education. In Mississippi, in 2018, the associate degree average, there's 17, for pass rate was 97%. In 2019, the rate was 97%. In the most recent report for 2020, the average again is 97%. The average pass rate for baccalaureate degree programs, and there are 8, in 2018, 98%, 2019, 97%, and in 2020, 98%. Registered nurses may practice in a variety of healthcare settings, such as the hospital, clinic, hospice, home health, school, industrial, or long-term care facilities. Once an individual becomes a registered nurse, they may decide that they want to advance their education and earn a higher degree, a graduate degree. Graduate degree programs in Mississippi schools of nursing educate students in the roles of clinical nurse leader, nurse anesthetist, nurse educator, nurse healthcare administrator, nursing leadership, and nurse practitioner. The nurse anesthetist and the nurse practitioner programs are program degrees in which the graduate is eligible to be certified as an advanced practice registered nurse. An advanced practice registered nurse refers to a registered nurse educated at the master's or postmaster's level in a specific role and patient population. Advanced practice registered nurses are prepared by education and certification to assess, diagnose, manage patient problems, order tests, and prescribe medications. In Mississippi, there are 5 schools of nursing that prepare advanced practice registered nurses at the master's or the doctoral level: Alcorn State University, Delta State University, Mississippi University for Women, University of Mississippi Medical Center, and the University of Southern Mississippi. I have provided a list of the role-specific advanced practice degree programs offered at the universities in Mississippi, along with their description. I was asked about the description of online. When a program is described as face-to-face, this is a traditional classroom-style learning with no portion of the program being offered online. Hybrid is a term used to describe the education delivery method of courses in which the instruction occurs using both distance education online and traditional face-to-face education methods of delivery. The description of an advanced practice registered nursing degree program option as online is also used to describe a program that offers courses required to graduate from the program online, but students must complete a clinical training practicum courses that do require direct patient care. The curriculum requirements and training for graduate programs are role-specific. All graduates must successfully complete core graduate courses, content specific to advanced physiology, pathophysiology, advanced health assessment, and advanced pharmacology, as well as content that is role-specific. In addition, students enrolled in a graduate program must participate in skills lab, simulation, and clinical practicum hours, providing direct patient care in medical care facilities specific to the role preparation program in which they are enrolled. When a program is described as online, does that mean the student can complete the curriculum and the clinical practicum training entirely online without ever participating in direct patient care? No. All advanced practice registered nursing programs require supervised direct patient care clinical practicum hours. In a nurse practitioner program, that would be by an advanced practice registered nurse or physician. And for the nurse anesthetist, it would be for a certified registered nurse with a certified registered nurse anesthetist or an anesthesiologist. The average number of direct patient care hours in advanced practice nurse practitioner graduate programs in Mississippi is 745 and 2,000 for the nurse anesthesia program. Advanced practice registered nurse certification is role specific and graduates must meet certain requirements. Examinations are competency-based and they reflect the knowledge and expertise in the role and the population of education. They must meet minimum of faculty supervised direct patient care hours for eligibility. Advanced practice registered nurse regulation includes education, examination and certification, and licensure. Licensure in Mississippi is governed by the Mississippi Board of Nursing. The Mississippi Board of Nursing verifies eligibility to take the national certification exam for nurse practitioner and nurse anesthesia graduates. Attachment 2 that I have in the handout, graduate program enrollment by clinical practice role, fall 2020. You will see that in fall 2020, enrollment in graduate degree programs was reported to be 800. If you look at attachment 3, that is master's and doctoral graduates, academic year 2019, 2020, and 2020. And you'll see that there were a total of 280 master's and doctoral graduates during the 2019-2020 academic year. You can see a breakdown of each role-specific category in those attachments. And again, the percentage of certification, the passage of certification exams by graduates is a quality measure of evaluation of advanced practice nursing programs that is monitored by IHL Nursing Education. Overall certification rates for all graduates taking nurse practitioner certification exams between 2018 to 2020 is 94%. The overall certification pass rate for nurse anesthesia graduates from 2018 to 2020 is 97%. And I'm happy to take questions or wait. Yes, sir. That's correct. Yes, sir. I don't have that with me. The outcome that we have, the standard at IHL is 80% over a 3-year period for NCLEX pass rates and board certification rates. The standard that we have at IHL is that pass rates will be 80% or above averaged over a 3-year period. Yes, sir. Let's see if I have it in here. I can get it to you. The national pass rate for the NCLEX RN in 2020 for first right only is 86.57%. And that's first time pass rate. Mhm.
I'm sorry, my microphone wasn't on. It's all going to be the end of me. So you were saying that the national passage rate, I think, is 86%,
Yes,
and
sir.
that the board only regulates those programs which actually are in the state of Mississippi. I'm just saying that to recap because my microphone was off.
I think I understood you. Yes.
And in order to enter an advanced practice degree program, is it necessary that one be a registered nurse?
Yes, sir.
And that's true with licensing and across the board.
Yes, sir.
So the first step is to become a registered nurse. Then after one is a registered nurse, one can enter an advanced practice program.
Yes, sir.
And looking on page 3 at the programs, I see that a number of our universities only offer online instruction. Is that something that's come about as a result of the pandemic, or is it that way before, or how did that come about?
That's just the trend now, is to try to offer more classes online. Online is just a description, but it's not, like I said, you have to take clinical practicum courses. They're face-to-face because you have to do direct patient care. And some of the courses would even be described as hybrid, such as the advanced health assessment course. So where you might could take some of the theory online, when you get ready to demonstrate your health assessment, that's something that has to be done with a, faculty supervised.
But that would not be the case where there are only online courses offered.
The online course, I'm sure there are some online courses that you can take that are completely online, but now they do have measures in place as far as secure testing and, to make sure that it's the student that's enrolled in the course, and the university, the institutions have policies in place.
I think, and I'm not sure that I understood everything, but I think you said that in order to become an advanced practice nurse, there were 4 courses in direct patient care that were required.
There's just certain core graduate courses, and then there are some other courses that are required. It doesn't matter if I'm going to be a nurse educator or a nurse practitioner or a nurse anesthetist. There are certain core courses that will be in that graduate program, and then you will go into more role-specific courses.
I perhaps misunderstood. I thought that you said there were 4 courses required for direct patient care, and that the average was 725 hours of direct patient care. I'm really having trouble hearing and also trouble understanding, but did I get that right, or am I?
They will take clinical courses, is what you would call the direct patient care clinical courses. That's correct.
And are those clinical courses online, or are they face-to-face with patients, or how does that work?
They're direct patient care, yes. They are faculty supervised direct patient care courses.
Okay. Do other members have questions? Senator Horn.
Thank you, Dr. Temple. And thank you, Mr. Chairman. I apologize if you went over this because I came in a little late. We have been told that we have a nursing shortage in Mississippi right now. Is that correct?
Yes, sir.
And included in your documents that presented to the committee, are there any recommendations that you all are making regarding how to deal with that shortfall of personnel?
There are quite a few things right now. We have a nursing faculty shortage. So our schools of nursing aren't able to admit to maximum capacity. So, we need to address, number one, faculty shortage to try to increase enrollment so that we can get those graduates out there. I don't have anything in this presentation addressing that.
If you had to name one or two short-term solutions to this issue, what would they be? And also if you had some long-term solutions, what might they be?
Short-term solutions, making sure we can get our students in the clinical facilities. They've allowed them to come back so that they can, when they're there, they can help their faculty supervise to help provide that direct patient care. But we've got to identify why we have a nurse and faculty shortage. Many nurses are leaving because they're tired and they're leaving to make more money. And so nurse and faculty salaries is something that we could talk about to try to get more nurse and faculty so that we can admit more students, and scholarships for nurses to go back to continue their education so that they will become nurse and faculty. And then just the resources in the schools of nursing as well. When you admit a lot of students, nursing programs are expensive to run because you have simulation labs and you have skills lab. And so a lot of funding.
You're seeing a lot of shortages amongst teaching personnel in nursing as well?
Yes, sir.
So what's happening to the personnel? Are they retiring? Are they going?
They're retiring and just various reasons retiring, and some have left to practice at the bedside. I mean, many of your nursing faculty are graduating, graduates who can go and make 2 and 3 times what their salary is. And so a lot of them have left to practice.
Thank you. Thank you, Mr. Chairman.
Thank you, Dr. Temple. And now for the Mississippi Board of Nursing, Dr. Johnson and Dr. Burks.
Good afternoon.
Good afternoon.
First, I'd like to thank the committee for this opportunity for the Board of Nursing to come before you this afternoon on this very important subject. And Mr. Chair, I am Phyllis Johnson. For those of you that do not know me, I am the Executive Director of the Mississippi Board of Nursing. We have several staff members from the Board of Nursing in the audience as well today. Dr. Burks is the Director of Practical Nursing Education for the Board of Nursing. And if the chair would allow, I would like for Dr. Burks to talk about the educational program that we have, and then I will talk about the regulation. So, Mr. Chairman.
Surely.
Good afternoon, Mr. Chair and the committee. Thank you all for this opportunity. I am Priscilla Burks, the Director of Practical Nursing Education, and I'm going to share some information about the PN programs in the state. The practical nursing programs, they prepare individuals to assist in providing general nursing care based upon the sciences: biological, physiological, emotional. Practical nurses in the state, they work under the direction of a registered nurse, advanced practice nurse, physicians, as well as licensed dentists. With the practical nursing program in your package, you'll see we have 15 programs within the state. Those programs are all approved and they are regulated by the Mississippi Board of Nursing. Also, you'll see there's a standardized curriculum. That curriculum goes from what we consider simple to complex. For every program, practical nursing program in the state of Mississippi, they are face-to-face. The practical nursing programs do not offer online. Also, in order to be approved as a program, they must be within the state located. When individuals complete the practical nursing program, in terms of lecture, and this is a one-year program, they will have 455 hours of theory or sitting in the classroom. In terms of being in the lab where they're learning their skills, it is 180 hours. The clinical component where they are out in the facilities, they're in the hospitals, long-term care facilities, clinics, doing hands-on under the supervision of a faculty member, that is 345 total hours. The total hours of the program is 980 hours. To be eligible for the program, this information is outlined in our standards. And the standards is what all the programs adhere to. Each school, their eligibility for individuals to enter the practical nursing program is, first they must apply, and they must apply to the college as well as to the practical nursing program. They must submit their high school transcript or college transcript. They can also have a GED. The unique thing about a practical nursing program is, for many of them, they do not require any prerequisites. No, so that's why it is very engaging to individuals, because they can enter this program, complete it within a year, and then go out into the workforce. For some of the schools, they do require them to have entrance exams. There are some other stipulations once they enter the programs, includes a criminal background check. They must have that done, clinical records, drug screens. Once they finish or complete the program, then they are eligible to sit for their boards or the NCLEX exam. For the accreditation component, all of the schools in the state of Mississippi, the practical nursing programs, they undergo a rigor component in terms of the things that they are expected and required to do to be able to admit students, and once they graduate, allow them to sit for boards. If a program is not approved when students graduate, they will not be eligible to sit for boards. The accreditation cycle takes place every 8 years. A group of individuals, they go out, they measure, they visit the schools, and they measure their outcomes in terms of how the students have done in the program. In the meantime, each year, the schools are responsible for submitting an annual report. And that annual report is looking at their completion rates in terms of how many students completed, graduated, and what was those scores on the NCLEX. Also, again, for the legal aspect of it, regulations, once the schools comply, then those individuals are eligible to sit for boards. Also in your packet, you'll see a list of the applicants or the number of individuals who actually applied for school for the 2021 school year. For the state of Mississippi and the 15 programs, they had 4,328 applicants. Out of that number, the schools were only allowed or able to admit 992 individuals. When we look at their NCLEX for the last few years, Mississippi pass rate for the national pass rate on NCLEX was 83.1%. National was 83.1%. The state was 86.7%. In 2019, nationally, it was 85.3. State was 85.6. For 2018, national was 85.4. The state was 85.91. So for the last 3 years, the practical nursing programs within the state of Mississippi have been above what the national average is. Thank you for your time. Any questions?
Thank you.
Thank you. Now, I have been informed that I am to talk about how we regulate nurses in the state of Mississippi. In order to do that, I think an overview of basically what the Board of Nursing is all about and what our mission is in order. I have provided for you a handout, but I will give a brief overview, and my remarks will be brief. But the Mississippi Board of Nursing has a very important mission in this state. And the mission is, we are a consumer protection agency. with the authority to regulate the practice of nursing through licensure as provided for by the Mississippi State Code. That is our mission, and it is a mission that we do not take lightly. The Mississippi Board of Nursing is composed of a board of directors, 13 members that are appointed by the great governor of the state of Mississippi. Let me give you a rundown of who is on the board of directors. There are 7 RNs, there are 4 LPNs, which are your licensed practical nurses. And for those of you that don't know what RNs are, they're registered nurses. There's 1 physician on our board of directors. That person is not appointed by the governor of the state. That person is appointed by the Board of Medical Licensure. There is 1 consumer on our board of directors, and that makes up the 13-member board of directors at the Mississippi Board of Nursing. So the Mississippi Board of Nursing, we are the largest regulatory agency in the state of Mississippi. The largest regulatory agency in the state of Mississippi. You have before you some information. We are responsible for the issuance of over 78,000 licenses in this state. Those are RN licenses and practical nursing licenses. We regulate the practice of the registered nurse, the licensed practical nurse, and the advanced practice registered nurse. We have over 50,000 registered nurses in our state alone. We have over 14,000 licensed practical nurses in our state alone. Some of those individuals have duplicate licenses. Some of them have been LPNs and they have matriculated on up the realm of becoming an RN or an APRN, which is your advanced practice nurse. So I've also been asked to talk about endorsement applications. We have nurses that endorse into our state. So first of all, what is an endorsement application? It is an application that is used to obtain licensure in the state of Mississippi if there is a currently licensed registered nurse or a licensed practical nurse who resides in another state and has never held a Mississippi license, but they want to come practice in Mississippi. They can then apply for an endorsement application. I was asked to provide over the last 5 years the number of endorsement applications that the Board of Nursing has received, and that is in your packet. But there's been a total over the last 5 years of over 5,600 endorsement apps into the state of Mississippi. Now let's talk about the advanced practice nurses, our APRNs. In the state of Mississippi, APRNs are defined as nurse practitioners, certified nurse midwives, and your certified registered nurse anesthetist. That encompasses what APRNs are in the state of Mississippi. There are 7,135 APRNs in this state. Of those, 6,142 are nurse practitioners. 966 are your registered nurse anesthetists, and 27 are your certified nurse midwives. The Board of Nursing is not a professional nursing association. We are regulatory. We work very closely with other regulatory agencies in this state. That is the Board of Pharmacy, and also the Board of Medicine, and when need be, the Board of Dentistry. So we regulate. That is our job, to fulfill the mission that the law has put forth that we need to fulfill to ensure the safety of the citizens of the state of Mississippi when they're receiving nursing care. So we regulate through the Nurse Practice Act, and that's 7315(1) through 37, that stipulates what we must do as a regulatory agency. We also regulate through the administrative code. The board promulgates the rules and regulations specific to practice for the nurses in this state, and that's all levels of nursing in this state. The Mississippi Nursing Practice Law defines the terms, it establishes the criteria for licensure, and it provides authority for us to do disciplinary processes. The administrative code expounds upon the law. The administrative code is authored by the Board of Nursing. However, we have to follow the Secretary of State process in the promulgation of rules and regulations in establishing the administrative code. That involves the administrative procedures process as well as the OLRC in any rules and regulations promulgated by the Board of Nursing. In addition to the Nurse Practice Act, there are other entities that are involved when we are regulating our nurses. That involves the CMMS requirements, which is your Center for Medicare and Medicaid Services, which is a federal entity. It also involves the Mississippi State Department of Health, rules and regulations. It involves the Drug DEA administration, because that involves narcotics. And then it involves the National Practitioner Data Bank. And that is a national data bank where any nurse or any individual just about in the healthcare field, that their discipline that is reported to the the National Practitioner Data Bank. So we work with all those entities in forming the rules and regulations and regulating the practice of nursing in our state. So how does the board protect the public? Just told you. We have licensure requirements. We ensure only duly qualified applicants are issued nursing licenses. And that's through our rules and regulations and the law. Then we maintain up-to-date regulations of the profession by determining the scope of practice and setting standards for these nurses. And then we enforce the sanctions that are afforded us through the authority of the nurse practice law on those who fail to abide by the law. I've also provided for you a handout that gives you the number by county in the state of Mississippi, a breakdown of the number of advanced practice registered nurses that are in the state of Mississippi and also in your county that you represent. They're broken down by nurse practitioners. They're broken down by the number of certified nurse midwives, and they're also broken down by the number of certified registered nurse anesthetists. So with that, I yield. And if you have any questions, I'm available, or if you'd like to wait, I'm available also. Thank you.
Thank you. I'd like to, if we could, just focus on the requirements for getting a license to be an advanced nurse practitioner. It's my understanding that in order to do that, you first must be a registered nurse.
That is correct, sir.
And it's my understanding that one of the ways you get to be a registered nurse is to have an endorsement application. That is to say, if you're a registered nurse in another state, you can then become a registered nurse in Mississippi. Is that correct?
They still have to meet certain requirements, but that is correct. Now, when you say endorsement apps from another state, they still have to meet requirements, educational requirements. And IHL spoke about our educational requirements. And we adhere to the standards of IHL's educational requirements regarding the education of all RNs. They must meet those educational requirements from an accredited school, and they must meet the standards that IHL has within our state in order to be licensed in our state.
Well, I'm not trying to be difficult about this, but it seems to me every time I have this conversation, I'm told by IHL that there are all these regulations that the Board of Nursing has. And I'm told by the Board of Nursing there are these regulations that IHL has. And I'm trying to get a grasp of this, and I'm getting more and more confused. The Board of the Institutions of Higher Learning has no control over nursing education outside the state. And so I'm a registered nurse from Alabama.
Mm-hmm.
And I show up and I've got my license from Alabama. What happens then? Do you take it's not merely showing up with a license from Alabama, but I have to have all my transcripts and everything, which then you send over to IHL for them to check. I'm just lost.
Okay.
Mechanically, how does this work?
Okay, let me answer that for you. If an APRN comes from another state and wants to apply here, they would endorse in our state as APRN, which means they would have to submit proof of graduation from an approved accredited program. They must have passed national certification and be board certified as an APRN in
Well,
order to endorse.
I'm just talking right now about nurse practitioners.
That's what I'm
I'm
talking about,
sorry,
sir.
I mean to say registered nurses. I'm always going to say that. But when a registered nurse wants to be a registered nurse in Mississippi, I show up with my license from Alabama. And so then what happens?
If it's a registered nurse that shows up and wants to come to our state, if they want to endorse in our state, which means they will live in our state, then they would have to meet the same criteria. They must show proof of graduation from an approved, accredited school of nursing, and they must have passed the NCLEX exam, which is the national licensure exam.
And what is an approved accredited school of nursing?
An approved accredited school of nursing is one that has met all of the educational requirements from the national certifying body, and that's under the Department of Education.
And can these institutions be online institutions?
Now, they could be online institutions.
And they exist outside the state of Mississippi.
Which we have no control over. Yes, sir.
So do we have people who are registered nurses who have gotten their education from an online institution that are trying to get a license in Mississippi?
I would think that there probably are some, although I don't have that data for you, but I would think there are because there are a lot of online educational programs, and especially since COVID, there have been more because of the lack of face-to-face opportunities to teach.
Well, I'm told there's something called Walden University, which is a large online university. And I'm told that there are a reasonable number of people who get their academic training from Walden University. Does this sound right, or am I confused about that?
There may be, but I don't have that data, and rather than speculate on that, I would be happy to provide some data for you if that is the case, but I would have to get with my licensure division to see if that is indeed the case here.
Well, it's a major concern as we go into this process of finding out what education and what experience ultimately advanced practice nurses have. And so I'm sort of trying to focus on this one step at a time. And I'm just trying to get a grasp around how it is that, assuming I'm right about Walden University, one gets an online degree from Walden University, but nevertheless has hours in direct patient care. And I don't know how that works.
Well, I'd be happy to look into that for you and provide you some data.
But I'm told by the people at IHL that you are the gateway, that the Board of Nursing is the gatekeeper about what sort of actual education people who are getting who are not from one of the institutions regulated by IHL.
And according to the Nurse Practice Act, that is stipulated that they have to have graduated. If that program is approved through the Department of Education, the law states that. And that's all that we go on what the law tells us to do to allow people to come in. If there is any discretion or question about a school, I'm sure there's probably another process outside of our process, but we go strictly by what the Nurse Practice Act has already delineated that they must complete in order to be licensed. in this state as well as in any other state in the United States.
Well, I want to be clear. I'm not suggesting you're not following the law. I'm just trying to find out what it is that the actual is permitted under existing law. And I think you tell me that if there is a nursing program that is accredited by the Department of Education, that there's no further inquiry into that, that's sufficient to meet the standard under law.
If they've met all of the approved requirements to graduate from that school, yes, sir.
And that some of these programs are online, and if whatever direct patient care requirement there is satisfies the Department of Education, then that of necessity satisfies your requirements.
Yes, sir.
Okay.
According to the law.
And so if again, now I'm a registered nurse in Alabama, and I want to get a license in Mississippi. And so I present to you my license from Alabama, and I also present to you my degrees, and you would look at those degrees just as though it was an initial application.
We would look at those degrees. We would also look at, do a criminal background check on those individuals as well. So that process involves not only just looking at their degrees, we'd have to get a transcript from the school. The school would have to provide a transcript, not the applicant. We only get it from the school directly to the Board of Nursing, showing that they have met all of the requirements of that school in Alabama or wherever in order to be licensed in any state.
Thank you. And I appreciate your being patient with me. I'm just
No
trying to
problem.
walk through this slowly to make sure I understand. So now we have got an explanation of how one becomes an RN. If I am an RN in Mississippi, I have a RN license in Mississippi, and I want to be an advanced practice nurse, what are the licensing requirements at that point?
They have to have graduated from an approved accrediting program, completed all the educational requirements of their program to become an advanced practice registered nurse. They have to have sat for national certification, which is a board certified exam in the role for which they have gone to school to practice. And they have to have passed that.
Is there a requirement for direct patient care?
I'm sorry, I didn't get
Is
the-
there an additional requirement for direct patient care?
They are educated when they go to school in the particular role of the patient care aspect they will be providing. For example, family nurse practitioner. They've been educated in that role. They're sitting for that exam, which is the board certified exam, which is the competency of having completed every educational requirement for that program and all of the clinical aspects and met those aspects of that program. So when they set for their board certified exam, yes, sir, they have completed everything they need to complete.
Well, I should explain my grandmother's maiden name was Walden, and she had an uncle who was a doctor at Becker. And I don't know that my great uncle from Becker is the Dr. Walden that has anything to do with Walden University, but it does help me remember my name. And in my old age, I have trouble remembering things. So I'm latching on to Walden University, and it's all because of my grandmother. But I'm assuming that Walden University offers online courses for advanced practical nurses. And the board's method of ensuring that that education is sufficient, including direct patient care, is that the program they're offering is accredited by the U.S. Department of Education.
Has to be, that's one of the entities, the Department of Education has to approve those educational programs. And then they have to be accredited and meet the standards of that educational institution.
Okay, thank you.
You're welcome.
Senator Blackwell.
Thank you, Mr. Chairman. First of all, to the nurse practitioners attending or listening online, congratulations. It's Nurse Practitioner Week. Don't know if you knew that or not. So congratulations. Dr. Johnson, thank you for coming. Do I detect a little military in your background?
Yes, sir. I am a proud U.S. Navy veteran.
And thank you for,
Thank you.
and can you tell us what you did in the service?
I was a nurse practitioner
You
in
were.
the service. Yes.
And how does the military handle nurse practitioners? Do nurse practitioners have full scope of practice?
They do? Yes, sir. Full scope of
Is
practice.
that through all of the branches and in the VA as well?
In the VA, they do as well have full scope of practice. As you are aware, the VA passed full practice authority, and the VA in Jackson, Mississippi, as well as on the Gulf Coast, now have full practice authority. The Indian Health Services, I believe, also have implemented full practice authority. Seems like there's one other entity. Who am I missing? VA, Indian Health Service, maybe that's it.
And are there any specific requirement for a certain number of patient contact hours before you can have that full scope of practice?
To my knowledge, and the ones that have been implemented, they have not attached any additional hours that they are required in order to have full practice authority.
All right. Thank you, ma'am. Thank you, Mr. Chairman.
Senator Johnson.
Thank you, Mr. Chairman. Thank you. Very remedial question. An RN, when they graduate, what is their role when they become an RN?
That is, okay. So as an RN, their role is to provide patient care. Now, they could branch out into different aspects. It depends on where they're going to be hired to work. Some do bedside nursing, some do clinic nursing, some go into administrative roles. So it varies. It depends on where they're hired and what occupation they take on once they graduated. Primarily, they are equipped with the competency to perform safe patient care and provide nursing services to any patient that they come in contact with.
And that's a prerequisite to become, to go to nurse practitioner school, is that correct?
Correct.
And how long is nurse practitioner school?
It varies. Most of them are 2 years now. With the doctoral program added to it, it can go anywhere from 2 to maybe 4 years or longer.
And then what role does a nurse practitioner have in healthcare?
The nurse practitioner is to provide assessment. They can diagnose, they can assess, they can provide the full gamut based on their education. And I use family nurse practitioner because I am also a family nurse practitioner. So we treat what we call cradle to the grave, and it's family practice. It's like your general family practice, family medicine. We are equipped and we are educated to provide those services. We can assess a patient. We can diagnose a patient. We can prescribe for a patient. We can treat a patient for those conditions that come into our clinical setting or our hospital setting. They serve as hospitalists in hospital units. They work on those units and they do patient rounds. They do assessment and they write and prescribe for those individuals. So there are various roles of nurse practitioners. Family is just one. You have your psych mental health nurse practitioners. You have your women health nurse practitioners, and they operate in those particular entities and provide the care that they've been educated and trained to do, specific to the role and foci for which they've gone to school for.
And so then how would, and say general practitioners, how would the training for a nurse practitioner compare to an MD nurse practitioner or general practitioner?
So that I can't answer for a general practitioner. I can just answer for a nurse practitioner. I think the Board of Medicine or the Medical Association may be able to shed some light on specifically what they do. I know there's a medical model that they're educated under. We were educated on a nursing model. However, that has evolved over time because of the evolution of healthcare And like anything else, it changes. And so as it changes, evidence-based medicine and evidence-based practice has shown what needs to be incorporated into educational programs going forward for both nurses and physicians.
And then throughout the state, I think there are several clinics that are owned by nurse practitioners. Is that correct? If there is any kind of issue when they see a patient, does it go to the state medical board or does it go to the board of nursing?
We regulate nurses in this state, not the medical board.
Okay.
And that involves nurse practitioners. I'm not trying to be, we're the regulatory agency for nurses in this state. If any, and we make visits. The law allows us to make visits, and we do, to every entity that we license in this state as a nurse practitioner. And we do not have to announce our visits. We make unannounced visits to make sure that they are in compliance with the law and the regulations, and that they are practicing according to how they have been educated and trained. So we make visits to those clinics as well to make sure that they're in compliance and doing what they're supposed to be doing. If there is anything that is reported to us, we investigate that instantly. And then we take the necessary action based on the authority given to us by the law to sanction those individuals.
And is there any information out there that I could see that compares not only the education between a nurse practitioner and say a general practitioner, if that was the role the nurse practitioner was taking, but also the standards maybe that are held at the Board of Nursing compared to the state medical board? Is there a way that I can compare the standards?
When you say standards, let me make sure I understand.
You mentioned that you hold nurse practitioners accountable to the level of education, but I don't know how that education varies with someone who goes to medical school. And so then is there a different standard that the medical board would hold doctors to than the nursing board would hold nurse practitioners to?
And that would be a question that I cannot answer based on what they do for their physicians. I just know that the standards are pretty cut clear because it's determined, their scope of practice is determined by their educational program, what they have completed, their education, their training, and then when they take that national certification exam, which I would tell you is not an easy exam, but it is a national board certified exam that they must pass in order to become a nurse practitioner. Once they've done that, that's their scope of practice. They're operating as a family nurse practitioner. They can't go out there and do surgery, because if they do, they're gonna call us and a lot of other people. However, their education is their scope of practice, and they can go and be educated and trained in that role, and then they are competent and capable of performing those things that they have been educated and trained to do. And trust me, if we find out somebody's not doing what they're supposed to do, we have a process to stop them from practicing.
Thank you very much.
You're welcome.
Just to follow up on one of the questions that I understood Senator Johnson be asking. If I go to an advanced practice nurse at a standalone clinic, and I go to a doctor at a standalone clinic, is the scope of practice the same for both of those?
Talk about the standalone clinic or what they can.
In other words, if I go see a nurse practitioner, can a nurse practitioner do everything that a doctor could do insofar as treating me?
For family practice?
Yes, ma'am.
Okay, you want me to be honest, right? Pretty much, yes, sir.
Okay.
Yes, sir.
Within,
they know what they're limited in as far as their role and folks out, but yes, sir.
okay, thank you. Senator McMahon.
Yes, thank you, Mr. Chairman. Dr. Johnson, I'm glad you're here. It's always a pleasure to be around you. We've had the opportunity to visit several times, and I always appreciate your energy that you bring to the room and your expertise. Thank you. I'm neither for nor against amending the current law. But here's what I am for. And I met with a group of about 30 nurse practitioners last night in the district that I represent because I wanted to hear from them. I'm for access to healthcare for hardworking Mississippi families. That's what I'm for. And whatever means we need to deploy or any law we need to change to give Mississippians access to world-class healthcare at affordable price that's readily available, that's what I'm for. So I'm here with an open mind trying to understand all the nuances. So a couple of quick questions. You said that you have 6,142 nurse practitioners currently under your authority of the board. Is that correct?
Get to my,
Roughly six.
roughly, yes.
Roughly 6,100, roughly.
Roughly,
So
that's correct.
in the last year, how many physicians who are operating in a collaborative have reported nurse practitioners for malpractice?
None to my knowledge. They've not reported them to the board of nursing.
Okay, 0 have been reported to the Board of Nursing.
Correct.
How many have been reported in the last 3 years, roughly? Any?
Not to my knowledge.
Okay. So there's no written infractions in, so there was no disciplinary against any nurse practitioner in the state of Mississippi to the best of your knowledge.
To the best of my knowledge, those will be reported to the National Practitioner Data Bank.
Okay. Fair enough. So do you operate any private practices yourself?
I do still practice on occasion because I love taking care of patients.
Do you currently operate within a collaborative? Do you operate within a collaborative?
I have to because we are a collaborative state.
Okay. I'm not going to ask you any additional questions because I don't want to put you in a position where you would be at odds with your collaborative. But I do appreciate you taking my questions, and I am delighted that you're here, that you're giving testimony.
Thank you.
Thank you. Thank you, Mr. Chairman. Mr. Chairman, I did have a question earlier for Dr. Temple at the appropriate time, if you would let me go back and ask that question.
Sure. I'm sorry. We're trying to get through the schedule and all, but I'll try to get back. Senator Blunt.
Thank you, Mr. Chairman. Thank you, Dr. Johnson, for coming here today and visiting with us. Roughly how many new nurse practitioner licenses are granted on average each year?
On an average, about 500.
500 a year
Is that nationally or
in the
locally?
state of Mississippi,
State of Mississippi, about 500.
about 500. And has that number gone up or down has that number gone up or down the last couple of years since the pandemic?
The data shows that the trends have increased over the last few years. There's been a slight increase in the number of nurse practitioners.
I'm interested in the governance structure of the board. The board, and you've given us a good handout here. How many members of the Board of Nursing are nurse practitioners?
Let's see, the board of directors. We
Right, I
have,
understand there are 13 members. There's no 13 members appointed by the governor, excuse me. There's no requirement that any of those 13 people be a nurse practitioner. They have to be an RN or an LPN or a physician or a consumer.
right.
So
and
how many people are nurse practitioners on the board?
Currently, I think there's only one that's a nurse practitioner on the board. Is it two?
Two?
Oh, two. I forgot. Yeah, there's two. There
Okay.
is two.
So what I'm learning today is I can't think of another licensing board that has so many different types of professions under one umbrella. You know, you've got RNs, you've got LPNs, you've got different specialties within the advanced practice scope. So what are the difficulties of a regulatory board with people of different educational backgrounds? Some may have a PhD. And what are the difficulties of a board regulating people when the majority of people on that board are regulating people who have further education than the board members themselves, if that makes sense?
Who have
That a
further
major-
education? Is that what you said?
Yes. So if you are a PhD, if you're a nurse practitioner or any advanced practice nurse, or you have a PhD in nursing,
you are subject to the regulation of a board. The vast majority of board members do not have the education that you have. You've gone to get a PhD or get a nurse practitioner's degree. The majority of the board does not have your level of education, and yet they regulate you. That seems like a challenging situation to me, because you need a board that has a comparable level of education than the people that they regulate. So how does that work with your board? And I know you work for your board, but I mean, what are the challenges involved in that? Should the makeup of the board be different? It seems to me that we should have people in whatever degree of education they've achieved, whatever scope of practice that they have, that they should be regulated by people who have an equal or greater than education than they do. So how does that work at the Board of Nursing, since you have so many different types of nurses out there that you regulate?
Well, as was mentioned, we do have 2 nurse practitioners that serve on the board. However, the
15.
basic educational requirement in accordance with the law is they must be an RN. And a registered nurse sits on the board.
Right.
If they want to go back and get additional education, that is their personal preference, but they still have to, the foundation is based on being a registered nurse. All you have to have is the knowledge of a registered nurse. If a nurse practitioner is brought before the board to be regulated, a nurse practitioner serves on that particular panel to make sure that they have input into whether this person did something that violated. We have attorneys, we have a legal system that our own attorney that serves on that. We have a representative, from the AG's office. So they have the basic knowledge of safe nursing practice, and that's to be a registered nurse. So,
but that level of education that they've received, which is sufficient for them to be a registered nurse, is less than the level of education that a nurse practitioner has received. And so a nurse practitioner is doing things in her scope of practice that an RN can't do.
however, if there's a nurse practitioner brought before the board to be regulated,
Okay.
we have a nurse practitioner out of these 13 members that serves on that particular panel to look at what that nurse practitioner has done. So there is their equal, their peer
Okay.
sits on that board to view whatever has been done.
So it's a smaller group that is
Yes,
out of the, was it
yes.
15
It's
people total?
dependent upon who's being regulated, who's been reported to the board. Then that determines, and our attorney has jurisdiction over that, of the panel that will be devised from this 13 member. And usually it's a 4-member panel.
Okay.
And it has to be, one of those has to be a peer of whomever is being looked at by that particular board for any type of conduct.
Should we, I don't know if you can answer this. If you can, I appreciate that. But should we, there's no statutory requirement that any nurse practitioners be on the board.
It only says that they have to be an RN
So
or an
maybe
LPN.
because you
that's-
have so many different types of nursing degrees and professions, maybe that's something that we need to think about, because it does seem to me that that anybody practicing her profession needs to be ultimately answerable to people of a comparable profession. But I don't know if you want to respond to that, but that's my final comment, Mr. Chairman. Thank you.
I have next Senator Parker and then Senator Horn, and then I think we probably should go on to another presenter. But first, live via satellite, we have Senator Wiggins, who wishes to ask a question. Somebody more clever than I knows how this can happen. I don't see it. Well, we'll move on with those who are here for sort of a face-to-face questioning. And we'll go to Senator Parker, and we'll see if there's any way to reach Senator Wiggins out in the ether. Senator Parker.
Thank you, Mr. Chairman. Thank you as well for being here today. Just in the discussion, there are a couple of questions that have kind of come up. I just want to just make everybody kind of clear of the answer to. Senator Johnson earlier was asking about standard of care. Is it not true that the nurses are held to the same, in a standalone practice, they would be held to the same standard of care as a general practitioner, in the sense that, for example, if they made an error or omission, say they missed a certain condition, they would be subject to being sued or have malpractice suit brought against them the same way a physician would. Is that correct?
That's correct. They carry their own malpractice insurance.
And nurses do not, they're not allowed to have a lower level of malpractice insurance because they're in the nursing profession. They're held to the same kind of standard limits in general practice that the standalone family practitioner might have. For example, I think usually aggregates start at $1 to $2 million per occurrence, and then you have to have a general limit of, 4, and then some people carry an extra umbrella on top of that. But is that the standard also in nursing?
Pretty much it's contingent upon what their specialty is with their family or women's health. But yes, you're correct.
So they're held to the same standard there. And then there was some question earlier that got me confused on the online issue. So there's no instance where we have a nurse practitioner in our state who has been through the whole process and has, gotten their RN and gone back and become a nurse practitioner and hadn't seen any patients yet. There's not a possible way to do that, is there, in our state?
Where they hadn't seen any patients, talking about prior to becoming an APRN?
Right.
Correct.
So they would have to get their RN. They would have to, probably to sit for the board, they would have to have a certain number of encounter hours or other hours in place to be able to sit for the practical to take the exam.
Correct.
Then they'd have to pass the exam. And then to be admitted into the nurse practitioner program, they would have to further demonstrate that they had done that and then get into that program. And then the same cycle would
Repeat
start
the same.
again. So
Correct.
it just seemed earlier that on the online issue, it got confusing. It made me, at one point, it sounded like you could kind of get through, just sitting in your home taking tests, but that is not the case, is it?
No.
Okay. Thank you for your answers.
Senator Horn.
Thank you, Mr. Chairman. Dr. Johnson, again, we appreciate your being here today. And as a state agency, the Board of Nursing is a state agency. Have you all taken, as a board, an official position regarding scope of practice, particularly as it relates to physician supervision?
Say that last part.
Particularly as it relates to physician supervision of a nurse practitioner. Has your board taken an official position one way or the other on that issue?
Well, right now, the law is the official position, and that we cannot function in this state without a collaborative physician.
Okay, let me rephrase my question.
Okay.
Do you favor a collaborative relationship with physicians as a board?
Do we favor it?
Yes.
Ooh, what my board of directors? That would be, the board has, we support nurse practitioners are all APRNs practicing to the full extent of their education and training. That's the board stance, that all APRNs should practice to the full extent of their education and training.
Are you sure you're not a senator, or you danced around that one pretty
I'm
good?
thinking about running after this, but. No, I'm just-
Thank you, Mr. Chairman.
Thank you. I have received a communication from Senator Wiggins. He is in court. He's not in the ether. He had a hearing he could not get out of. He sent me 2 texts. One of them says he has just been called into court. Another appears to say he has been called out in court. And we look forward to having a face-to-face meeting with Senator Wiggins at some future point to decide what actually happened to him, assuming he's not in jail. just one other thing, Dr. Johnson, and I want to thank you for coming and the time you spent with us. And at my request, you provided this list of counties where nurse practitioners reside, I believe. I would ask that at some point you review that. Just hurriedly looking at this list, it shows that there are 21 nurse practitioners in Issaquena County. Issaquena, of course, is a very small county. It shows that there are 11 in Humphreys, that there are 5 in Sharkey. And even if you get to Warren and Washington counties, this shows that there are 33 nurse practitioners in Warren County, 37 in Washington, but nevertheless 21 in Issaquena. So unless there's a hotbed of activity in Myersville or Valley Park, it just, and there are other things that seem odd. It shows only 5 nurse practitioners in Union County, but once again, there are 50 in Benton County. So I would just ask that you review that to see if it needs to be modified. But thank you very much.
Thank
And I want
you.
to join others who thanked you for being here. It's a very useful presentation. And now we have as our next presenter, the Mississippi Association of Nurse Practitioners, Ms. Glasgow, Mr. Ware, Dr. Ware.
Good afternoon. Thank you so much for inviting us to attend the hearings today. It's so nice to see you. I see Senator Tato there. I remember seeing him at one of our dinners, and Senator Blackwell, who is from DeSoto. That's where I practiced for 20 years in the ER there, kept that community moving and safe, hopefully. And so I want to say thank you for the opportunity, Chairman. I really appreciate it. I'm Ann Glasgow, and I'm a DNP. I have several years of experience. Hate to admit it, I had 20 years as an RN, which was in acute care, education, and long-term care. Also, I had, as an NP, I practiced for another 20 years in the ER, because that's just sort of my love, going back to when I was 18 years old. I am married to a physician, which is an oddity in some of these cases. He's very supportive, and he was my collaborative off and on when I would help in the clinic. Our collaborative time was a lot of time pillow talk at night or on a trip or something, where we were collaborating about our patients, trying to help each other. And so in essence, that was our pillow time, trying to improve the care to Mississippians. Strange pillow talk, right? I wanted to get into the scope of practice. We are not asking for the change in the scope of practice. What we are supportive of full practice authority according to our education, training, and expertise with transitional hours. And those hours are the hours given following our training as past the collaborative so that we can assume the full practice role. Those hours we vary from state to state, but we are supportive of those transitional hours. You have to ask what happened to increase the primary care need. How did the NPs come about? I gave you a packet that's got a little bit about the history there. I'm not going to all of it. The main thing is specialization of the physicians in the 50s and 60s evolved, which we love having all the different specialties. They really added a lot for our healthcare. And what they had to do was train nurses to oversee some of the shortages. They had to bring in nurses, RNs to those areas because the docs left in those areas were there alone. The specialists go into the town and they set up their specialties. So then therefore it left the country docs there alone. So in came the nurses. The docs did subsidize them, mentored them, and trained them. And so we ended up with a subsequent in 65 education developed for the NP. We have a young profession, basically compared to the MDs. With the education, there was a university set up in Colorado with a doctor there. And with these changes of education to meet those needs, then many of the doctors and nurses faced a lot of adversity as to, well, what roles do we play? What policy, what regulations? What are the competency measures that we must overtake? A lot of things you were asking already to the Board of Nursing. Along came with that inconsistency nationally in the states. None of the states had the same as they evolved. Along came new federal guidelines. The Johnson era, the Social Security amendments, Medicare, Medicaid program, once again, you got increased uninsured individuals there. The Obama Affordable Cares Act, another group of insured. And then once again, you get increased uninsured along with that. The Trump era, the CARES Act, the pandemic, golly, you know, you got more uninsured there because a lot of people have lost their jobs. They don't have health insurance like they did, although a lot of the medical care has been assumed by different entities. The uncertainty and disruption of our life from the pandemic has led to disruption in care and challenges, especially mental health. We've got shortages in mental health in different areas because now then we're seeing with the pandemic an emergence of a new era where we need individuals out there to assist with mental care, with stress related, with depression, with all these entities of loneliness. Such as with some of the elderly populations that feel like they've been isolated. My parents was that way. I just lost both my parents about a month ago. My mother was COVID pneumonia. My dad was liver failure. So their loneliness, I'll never forget. That's something that all elderly people face when the pandemic comes along and they're told, hey, you can't come into my house. You can't come into the emergency room with me. You can't go in the hospital. So we've got some true issues out there, and we're going to really need to beef up and look at the mental health. We're training the nurse practitioners in that area, but they're having shortages of preceptors. They're having and collaborative physicians to help them meet those needs in our community. So once again, we have got to step that up and look at entities on how to do that. We do have in the state of Mississippi, the 6,000 MPs, as they said. And so we are making great strides with increasing the education. I have a chart, go back to the chart where, this little chart here. You all have this. It's a wonderful little chart that tells you about the nurse practitioners. They provide choice of care for millions of Americans. They evaluate patients, they diagnose, they write prescriptions, they provide a comprehensive perspective of health. The NPs become a partner. They have a track record of quality health care. In your packet at the very back of it, you will see a list of studies I provided because so many individuals want to know about the quality of care. Well, in some areas, it may be a little, comparable to the MD. Many of these studies show that. You look at the PAs and the nurse practitioners and MDs that you're seeing, and it is comparable. We've had zero, as far as we are aware of, malpractice claims. And that says a lot to us, as was answered by your last speaker. We have those less claims. So therefore, we must be giving some quality care to our patients. We have had a track record for nearly half a century, 5 decades, improving potential patient access and quality care. So we've been doing it, like I say, for 5 decades. We provide visits annually, about 1.06 billion in prescribed medications in all 50 states. So we're looking at a solution to a lot of the access to care, patient-centered, accessible healthcare given by the nurse practitioners. Of the nurse practitioners, 89% of them are prepared in primary care. That means, once again, 7 out of 10 give or deliver primary care to the population. We have approximately 69.7% that are family practitioners. We have 20.7% adult and geriatric, 2.2% women's and health, and then 3.9% pediatrics. So we're looking at covering the broad spectrum there. I'm not going to get into the requirements of practice. I think they've already spoken about that. But we do have to have our baccalaureate degree. We do have to have our RN, and we also have to have a passage of a licensure exam, certification exam, in order to even become a practitioner. There are 2 entities that give the certification, AANC and then AANP. And they're both based in the United States, and they've been very active and have a good history behind them. Increasing numbers across the scope in the United States, as you can see, since 2001, we've had a drastic increase there. 2021, around 325,000. So we're increasing in numbers. By the numbers, the NPs provide 81.0% of Medicare patients. They provide 78.7% of Medicaid patients, 83.7% with the primarily uninsured patients, and then 51.5% see uninsured patients, which is very important. You see a lot of practitioners going to rural, undeserved areas. That's what I did. I went to Marks, Mississippi, and practiced over there in the emergency room. I went to South Haven, Baptist Soda ER. That's when the Central imploded Central downtown, and boy, here came a large crowd of people from downtown Memphis and the Delta that sought care over there. So I saw a large number in that emergency room. Go to the next one. The main thing is that the quality of care, as I said, has been comparable. It's been safe, effective, patient-centered. Fewer, you've noticed that a lot of the RN nurse practitioners have fewer unnecessary hospital readmissions, fewer potentially preventable hospitalizations, higher patient satisfaction, and fewer unnecessary ER visits. A lot of those studies will show you that I put in your packet. And they've become the frontline pandemic healthcare providers during this particular period of time. 2030 projections for Mississippi physician shortages. This particular study was put out by the Robert Graham Center, and it was projected between 2010 to 2030, there would be an increased need of primary care physicians. And if you notice with the graph, we got your little Senate over up there. The graph up there shows that at the end of 2030, the need will be 36% there will be needed 132 PCPs due to age, and 45% of which is about 165 PCPs due to population growth, 18% or 67 PCPs due to Affordable Care Act, which is increased insured population. That means 364 primary care physicians by 2030. Another study that I showed available was the Commonwealth Fund 2020 scorecard on the state health system performance. They grade all the states in the United States. Mississippi ranked 50th out of 50 as far as available physicians. So once again, if we're still ranked low, then having enough PCPs and we're at the bottom, we need to look at ways to improve this. This next slide shows that, yes, they did work on the model there, which shows that Mississippi is below. You can barely see it right there as far as the demand. But it shows that physicians under the Graham Act Center that they have made steps in dedicating funded to primary care medical education. They're increasing funding to primary care training programs, medical school students. I did see where the physicians was like an increase of 135% in the medical schools. So they're making efforts, but this is 8 years out from 2030. That was 12 years ago. We've got the population of nurse practitioners increasing and that have been trained that can pick up the load, that can help with the load in providing that care to the communities in rural areas and underserved areas. Governor Tate Reeves and Speaker Philip Gunn in 2014 in their health initiative, Building a Better Health Care System in Mississippi, they included NPs as a vital building block in the healthcare system to do that. And we are very supportive of that. Full practice authority, what is it? What are we asking for? Well, full practice authority means the NPs are authorized to evaluate patients, to diagnose, order, interpret diagnostic tests, initiate and manage treatments, including prescribed medications, on the exclusive licensure authority of the State Board of Nursing. We have a very strong board that rigorously licenses us and monitors us. So our goal is optimal health, prevent illness, reduce health disparities, and improve access to care. And how do we do this? We support integrated health care by putting patients first. That's what we support in MANP. Our organization is young, 7 years old. We support Mississippians' care, access to care. We also support the practitioners in the state of Mississippi. We're the only organization that's run by nurse practitioners, and we have a board made up of 10 nurse practitioners, and we operate at a volunteer level. Well, none of us are paid to do this. This is only volunteer. It's time away from our families and work in order to support the access to care for Mississippians and to support our NPs. And we must support our roles with each other. I think that we can, we're not trying to be the doctor. We're trying to be the nurse practitioner that we were trained to be, all of us. Robert's going to pick up next.
Mr. Chairman and committee, I thank you for the time that you have given us for this. I want to discuss briefly about the collaborative agreement, what it is and what it is not. You know, in the state of Mississippi, as Dr. Johnson referred to earlier, we have to have currently a collaborative agreement in order to practice as a nurse practitioner in the state of Mississippi. Removal of the collaborative contract, often referred to as full practice authority or FPA, is allowing nurse practitioners to function at the full extent of their license, education, and training. Full practice authority is not an expansion of scope of practice. It does not allow the nurse practitioner to do anything more than what we can do today. For example, I hold dual certification in acute care and family medicine. I cannot practice as a mental health nurse practitioner without returning to school for a full program, full educational requirements, sitting for a national exam and successfully passing that exam before I could even practice in the area of mental health. To date, more than half the states in the United States have passed full practice authority or removed the collaborative contract. Removal of the collaborative contract does not prohibit anyone from entering into any agreement with a physician, nor does it supersede an employer's policies and regulations. So regardless, if I go to work as a nurse practitioner for an organization, whether I have full practice authority or not, or if I go to work in a physician's office as a nurse practitioner, I still have to abide by that practice's policies and procedures and regulations. However, with the current law regarding the contract, physicians totally control whether a nurse practitioner can or cannot work. The collaborative agreement, without it, regardless of how many years I've been to school, how many years I have been a nurse, or how many years I've been in any practice, I cannot practice as a nurse practitioner if I do not have a collaborative agreement. Also, this could mean, because of the collaborative agreement, this could mean that a nurse practitioner working in a family clinic or who owns a family clinic would have to have at least of a minimum 2 collaborative physicians. You would have to have your primary collaborative physician who works with you, and you have to have a backup collaborative physician, which substitutes if your primary collaborative physician is outside the mileage range, which is dictated, or if that collaborative physician is on vacation, becomes ill, or is incapacitated. So at a minimum, a nurse practitioner should have 2 collaborating physicians. Once again, that is your primary and your backup. The collaborative agreement, whether intentional or unintentional, can also limit access to care in natural disasters and pandemics. Unlike nurses or registered nurses, nurse practitioners are not as mobile in these situations. A nurse practitioner cannot go and volunteer and provide care in emergency shelters, clinics, or other locations without having a collaborative physician at that practice site. So during the COVID pandemic, some governors, such as in Louisiana, removed that collaborative agreement so that they could bring other providers into the state to help relieve the burden of their overworked and tired practitioners that were there. In Mississippi, that was not possible. In one incident that I am aware of, that FEMA brought in a practitioner to assist in an emergency room in the area. She could not practice because the contract group, which is understandable, did not know her and had no relationship with her. So they would not serve as her collaborative agreeer, and neither did the hospital, because it was in a specialized setting and there wasn't a physician on staff there that was an emergency physician who could serve as her collaborator, because you have to practice in like practices from the collaborating standpoint, which means that if you have a collaborator who may not see anyone, and you're a family nurse practitioner, and you have a collaborator who may choose not to see anyone under the age of 15, that means you cannot see anyone under the age of 15. You're going to have to find a second collaborator who sees children from birth to age 15, and you're going to have to contract with them as well in order to be able to practice to the full extent. The Mississippi Association of Nurse Practitioners supports transition to practice hours before the collaborative contract is removed. In short, we do not believe that an individual who has just graduated from an approved program, passed the national certification boards in their area of practice, should be allowed to immediately start practice without first practicing within a collaborative agreement. We are held to the same quality standards by Medicare, Medicaid, and the commercial payers when you start looking at outcomes. Just because you're a nurse practitioner does not mean you get a pass from those payers to do substandard care. You can't. You're held to the same standard, or you're not going to be paid. You're not going to be a part of their network. And so we're held to the same standard as the physicians from that standpoint. As Ann mentioned, the Commonwealth Fund 2020 score, it's a huge report, but I encourage you to go out and look at it because it provides you a lot of information with that. Mississippi ranks overall nationally 51 out of 51 and 12 out of 12 among the southern states. In availability of care, we're ranked 50, and it is in vast rural areas and underprivileged populations that are least likely to have access to medical care and most likely to have the worst outcomes, especially in following pandemics. This chart is in your packet as well. Of the 25 plus states who have removed the collaborative agreement, 8 rank in the top 10 in the categories of access and affordability, prevention and treatment, avoidable use and cost, healthy lives, and income disparity. 18 of these states rank in the top 25 in those same categories. It is time for a change. We cannot continue doing the same thing the same way we have always done and expect to get different results. You might ask how removal of the collaborative contract will benefit Mississippi and the patients we serve. Adopting FPA, or removal of the collaborative agreement for nurse practitioners, provides patients with full and direct access to all the services that NPs are equipped to provide. Improved access for FPA creates greater access to care, especially in the underserved urban and rural areas. States with full practice authority are more likely to have NPs working in rural and underserved areas and NPs practicing than states with more restrictive licensure models. FPA streamlines care and makes care delivery more efficient. FPA provides patients with full and direct access to that service at the point of care. It removes delays in care that are created when dated regulations require an NP to be a part of an unnecessary regulated contract with a physician as a condition for practicing their profession. FPA decreases cost. It avoids duplication of services and billing, cost associated with outdated regulations of oversight of NP practice. It reduces unnecessary repetition of orders, office visits, and care services. It protects patient choice. It allows the patient to see the healthcare provider of their choice. It removes anti-competitive licensing restrictions that interfere with patient-centered health care. Once again, I thank you for your time, and I'll be glad to entertain any questions that you might have.
At this point, I think it would be well to move on to Ms. Lavanos with the National Council of the State Boards of Nursing. We're running over on time, and I think in order to hear all the presentations, we probably should hear from her now.
Waiting for my PowerPoint, pardon. Chairman Bryan, members of the Senate Public Health and Welfare Committee, thank you for having me here today to talk about this important issue. My name is Nicole Lavanos, and I'm the Associate Director of State Advocacy and Legislative Affairs at the National Council of State Boards of Nursing. NCSBN's aim is to assist state boards of nursing in their mandate to protect the public. I will use a short PowerPoint to guide my presentation today. And first, an overview of what I'll speak of. An introduction to the APRN consensus model. Next, the regulatory framework for APRNs across the country, the state of the states, focusing on recent efforts as well as actions taken during the COVID-19 pandemic. And last, but most important, how the evidence shows us that removing barriers results in wins for patients. The APRN consensus model, of which NCSBN is an author, was adopted in 2008 and set standards for licensure, certification, education, and practice of APRNs. The model is evidence-based and patient safety focused. The full practice authority provisions of the model are of interest today, obviously, and the ability for APRNs to practice to the full extent of their education and certification is demonstrated by decades of evidence, demonstrating that APRNs are both safe and quality healthcare providers. Uniformity is the goal of the model, and uniformity in APRN regulation and practice is critical for patient understanding of their healthcare providers, and it is necessary for the growing borderless and mobile healthcare environment. By focusing on only those elements necessary for safe APRN care, the model avoids the burden and the risks associated with unnecessary regulation. Boards of nursing are the historical and appropriate regulators of APRNs. In addition to licensure of APRNs and enforcement of the Nurse Practice Acts, Board of Nursing members and staffs are experts in regulating APRN practice, education, and certification to ensure patient safety. In all states that have modernized their APRN statutes to remove collaborative practice agreements, APRNs are regulated appropriately by the boards of nursing. It's under that framework that we have the evidence that of quality outcomes and safe care from this policy change. Next, we'll look at the state of the states. Currently, over half of the states have removed collaborative practice agreements for one or more APRN role. 24 states, the District of Columbia and Guam, have removed these barriers for nurse practitioners, including, and that number grew by 2 in the last legislative session, when both Delaware and Massachusetts enacted full practice authority. APRNs with full practice, as was mentioned earlier, are practicing in Mississippi today. including nurse practitioners, clinical nurse specialists, and certified nurse midwives enjoying full practice authority within the VA and the military, as well as Indian Health Services. The COVID-19 pandemic saw state and federal action to reduce and remove barriers to APRN care. 12 states took emergency action, either through executive order or emergency legislation, to remove collaborative practice agreements for APRNs. That's 12 otherwise restricted states taking action to remove those collaborative agreements. They saw it necessary to immediately waive the need for these agreements to mobilize APRNs and provide for patient care and greater access to that care during the unprecedented public health emergency. Many of these actions remain in place today, including in neighboring Louisiana, where APRNs have been practicing without a collaborative agreement since March of 2020. And one state, Massachusetts, made the waivers permanent, enacting full practice authority in January of 2021. Additional state actions, such as licensure waivers and telehealth exemptions, dealt with the mobility of practitioners, both in physical practice and telehealth. The Trump administration called for removal of collaborative practice agreements in March of 2020. Each governor was sent a letter from President Trump's HHS secretary calling for waivers of scope of practice requirements. That includes, quote, any requirements for written supervision or collaboration agreements in order to avoid significant delays in provision of services. CMS also took action to increase access to APRN provision of care. That included suspending the CRNA supervision requirement. Arizona Governor Ducey permanently opted out of the CMS rule during this time. He cited an increase of access to care for CRNA anesthesia services during the pandemic. The Veterans Administration also took action to increase access to CRNA care during the pandemic, and efforts to make full practice authority a reality for CRNAs in the VA system are ongoing. Of course, all of these actions were taken so APRNs could safely provide needed care to practitioners during the COVID-19 crisis. Examples of APRN participation in the response include providing primary care services, whether it be testing, treating, and vaccinating patients, providing mental health care. That need exacerbated, we know, by the financial and emotional strain of the pandemic, providing critical and acute care services for those sickest COVID-19 patients, and providing care via telehealth to offer continuity of care for their existing patients, as well as allowing access to care for new patients. The APRN workforce in states without barriers, or those who've waived barriers temporarily, practice was more mobile. Facilities were able to make workforce decisions as needs arised and shifted. And it allowed APRNs to take positions such as volunteer positions or employment opportunities to respond to the needs and respond to hotspots. In states without barriers removed, the opposite occurred. The unnecessary regulations resulted in a less mobile workforce and restricted practitioners operating within their collaborative practice agreements, which oftentimes had office and practice restrictions that we heard of previously. Mississippi did not join the 12 states who removed the collaborative practice agreement during COVID-19, and they've not yet joined the 24 states who've removed barriers permanently. But with an abundance of evidence, we don't have to assume or guess what the outcome of the policy change will be. The next several slides have examples of citations from the research that focus on access to care, patient outcomes, strengthening the APRN workforce in a state, and collaboration among providers. I'm going to highlight just a few. I won't go through each. When you look at access to care for Medicaid patients, as states look to increase access to care for these vulnerable populations, states have found that increasing access to APRN supports care for the Medicaid population, in addition to reducing the cost of care for caring for that population. Maternal health outcomes are also benefit from full practice authority. Maternal outcomes, including late stage cancer diagnoses have been reported to be lower in states that remove practice barriers for APRNs. Oop, I apologize. Sorry, the slide focuses on rural health, finding that NP supply grew in rural and healthcare provider shortage area counties, regardless of scope of practice regulation, but NP supply was higher in those states with full practice authority. We can also look to workforce and access data that we see from this real policy change that's happened in 24 states in the District of Columbia. We see that in Arizona and Nevada and North Dakota had significant benefits to their rural communities. Arizona saw the greatest increase in providers after passing full practice authority in their rural counties. Healthy workforce to increase access to care. A healthy workforce and access to care really go hand in hand. So essential to patient safety too is a robust workforce. This is promoted through practice environments that promote faculty recruitment, reducing barriers to recruit providers, and also maintain highly educated APRN students in the state where they graduate more easily. As healthcare modernizes and provision of care through telehealth grows, removing unnecessary barriers will also promote telehealth businesses and participation in the state. Last but definitely not least, collaboration. Safe and effective patient care involves collaboration among providers. Concerns over losing collaboration by removing the CPA barrier, the collaborative practice agreement barrier, have been expressed. But among the existence of collaboration between providers in 50 states, of which there's evidence in all states, as you can imagine, that healthcare providers collaborate, those with full practice authority and those restricted, and this collaboration occurs across specialties and across all facility types. Mississippi House Bill 1303, which advanced out of the House chamber in the 2021 legislative session, actually provided that APRNs collaborate and consult as appropriate to patient care. It's possible that in Mississippi, APRNs will be the only provider in the state to codify this important and inherent element of healthcare practice. The evidence is clear. Greater access to care, quality outcomes, promoting a healthy workforce, and maintaining collaboration among providers means patients win and access to care wins. Thank you for your time.
Thank you. At this point, I think we'll stand in recess and we'll reconvene at 3:20. It's time for the committee to reconvene. We're ready for our next presentation. You see wayward senators out there. We're going to send for the sergeant at arms if necessary. I have enforcement at my beck and call. I think we can arrest absent members and force them to come. We could hold them for ransom, but then who would pay? Thank you. And now Dr. Teresa Kemp Rogers is next. Dr. Kemp Rogers.
Thank you, Chairman Bryan, for the opportunity to present to you today. And thank you to the members of the Senate Public Health Committee for the chance to advocate as a Mississippi physician for Mississippians as patients. My name is Dr. Teresa Kemp Rogers. I'm a native Mississippian and emergency medicine physician in Laurel, Mississippi. I work as a hospital administrator and chief quality officer at South Central Regional Medical Center, a level 3 trauma center in a rural area of Mississippi. I'm here as a member and a volunteer of the Mississippi State Medical Association. At this point, full practice authority has been presented to you for at least the last 7 years. The language of each bill has largely been the same. And my goal is to share with you observations not only as a hospital administrator and physician, but also as an educator of medical students, residents, and nurse practitioners. My aim is to give you a new look at this issue with data that is up to date, relevant, and specific to Mississippi. But most importantly, I will work to look beyond the individuals in this debate, beyond the physicians, beyond the nurse practitioners, and instead take a patient-centered approach. My role is to help you keep the balcony view as you listen to both sides of the presentation today. This is not a critique of the current education system, licensing, or regulatory process. It is a critique of the request for unregulated medical practice. There's three major takeaways that I would like for you to know. The first is that educational differences support continuing the physician-led team. There are challenges with nurse practitioner education that have not been discussed to this point. Nurse practitioners are a young discipline when compared to modern medicine. Prior to 1965, there were no nurse practitioner schools. There was not an accreditation process until 1998. And within 3 months of that accreditation process being started, over 300 schools were preliminarily approved. Today, there's over 400 nurse practitioner schools. And what you may not know at this point is that 20 of those schools have a 100% acceptance rate. 49 of those schools have 100% online education for preclinical courses. Preclinical courses are where diagnostic reasoning is taught. There are no medical schools that teach diagnostic reasoning online. There is no evidence that it can be safely taught online. Going back to nurse practitioner schools, there are many that don't set up rotations for their students. There are many that don't screen the precepting physicians or assess the students after the rotations. How does this affect the quality of the education? And what does this mean for patient safety when we don't know the quality? These online medical schools with 100% acceptance rates prey on nurses who want to further their education and provide a better life for their families. Walden University is currently being investigated by the Department of Justice and Education for those reasons. The reference for the SEC filing is in the presentation at the end. I can show you that at the end if needed. In some ways, nurse practitioner education is where physician education was 120 years ago. In the early 1900s, medical education was under scrutiny for abbreviated and unstandardized training that led to poorly trained physicians. The Flexner report highlighted these deficiencies, and because of this report and a call to action to protect patients, many medical schools were permanently closed. The rigorous medical school accreditation standards we have today were born out of those experiences. With our NP colleagues, we look forward to increased regulation of NP schools. And with our NP colleagues, we look forward to increased scrutiny and what it will mean for upholding the nurse practitioner profession and what it will mean for patient safety. Until that time, it's difficult to advocate for full practice authority simply from a safety standpoint. Moving past regulatory concerns for nurse practitioner school, I'd like to briefly address the differences in education. But before we go here, I believe, and many physicians believe, that the educational standards for nurse practitioners supports the current team-based approach. The current NP educational standards do not support the request for independence. There's a dramatic difference between nurse practitioner and physician education. NP school is not medical school, and clinical authority in the field of medicine is with physicians. The education of nurse practitioners supports what they do now. So with that, we'll review a little bit of data. You've probably seen it before. Doctors go to school for a long time. We know that. These are the prerequisites. We talked about the prerequisites already, so we don't have to do that comparison, and I can move past it. But we go to school for a long time. Here's a slide that shows the differences and what happens in that time. There's standardized objectives for each of these courses. There's licensing exams just at the end of the preclinical courses. These are clinical rotations, and it highlights the difference between the physician and the nurse practitioner education. And at the end of the core rotations, there's a licensing exam. So what that means is when a medical student goes on a rotation, they have to take a national board exam at the end of that rotation. So this slide shows the difference between the supervised clinical practice. For physicians, it's called residency. We do a lot of hours there. And then for nurse practitioners, I believe it's called monitored practice hours or transitional practice hours. And as of April 16th, 2021, those were removed. Here's a difference between the licensing exams. So for me, the take-home point is that where the scope of NP training reaches its limit, it's the physician's role and responsibility to be the established backup plan. The physician-led team is a safety net. And it should be noted that it's not just a difference of duration. It's also in the content and the subject matter and the depth. And I show you these slides to highlight the differences in education and to promote the current framework. These differences support holding the current pattern. We agree that scope should be commensurate with training. My current job at the hospital is to know the CMS standards for our hospital, to oversee the process to ensure that we're following those standards and to identify areas of risk to our patients. And I decided to take this approach and apply it to medical school and nurse practitioner schools. When anyone advocates to remove the physician-led team, that is the safety net around the patient, that's where we'll have safety and quality issues arise. Objective evidence of these safety and quality issues is clear when you look beyond the hours comparisons. If you look at the accreditation standards for medical school, it's explicit that medical school is dedicated to preparing the students for the practice of medicine. Medical schools have to ensure that 100% of their students learn to be sufficient breadth of knowledge to be the authority in the field of medicine. Medical schools have to guarantee that 100% of their students learn the processes necessary to accurately diagnose a patient. Medical schools have to identify gaps and close those gaps in their students' knowledge. And perhaps most importantly, it's explicitly written that medical schools have to teach their students how to recognize their own limits. This means that because they're written as standards, when the accrediting body shows up to a medical school, they can say, prove it. Prove that your students know how to safely and accurately diagnose any patient. Prove to me that your students, 100% of them, are taught to recognize their own limits. And the school would have to do that. This is necessary because it's such a vital skill to ensure the safe practice of medicine. On the other hand, when you read the NP school accreditation standards, it is not explicitly written in there. They do not teach sufficient breadth to safely support independence. They do not guarantee that 100% of their students learn how to diagnose. And they do not teach their students how to recognize their own limits. And it's because these values are not part of the accreditation standards that risk arises for patients. And so since there's no accreditation standard that they all should do this, the accrediting body cannot hold them accountable when they do not. A 2019 study from the Risk Management Foundation of Harvard examined the malpractice cases arising from NPs, and it was clear NPs are more likely than physicians to have malpractice cases related to missed diagnosis. And this is not unexpected given the differences in training. But it is yet another reason to continue the strong team-based relationship between a nurse practitioner and a physician. The last point I would like to make under the heading of education has to do with teamwork data. The data supporting teamwork goes back as far as World War II. It really took hold in the 1980s with aviation and the development of crew resource management. So in reality, talk of silos and independence is unsafe and outdated. Medical school training explicitly teaches teamwork and interprofessionalism for this reason. And what is perceived as a burden by a minority of nurse practitioners is viewed as safe and protective by the entire house of medicine. We've spent a while here, but it's such an important aspect to this discussion. Educational differences in content, teamwork, and safety support continuing and upholding the physician-led team. The second takeaway is that all Mississippians deserve a physician-led team to provide a strong safety net of care. Today, when medical care is provided in Mississippi through a team-based approach, it's held to one standard: medical. The definition of the practice of medicine is codified. It's codified, and as stated before, nurse practitioners do practice medicine by diagnosing and treating patients. And with our current system, it means that regardless of who is seeing the patient, there's some sort of connection to medical training, whether it's through the collaborative agreement to the medical board. This means that Mississippi law reinforces that all Mississippians have a right to the most thorough, detail-oriented, and accurate care, regardless of how vulnerable they are, regardless of their socioeconomic status, regardless of their voting district. The most vulnerable, sickest patients deserve the opportunity to be evaluated by someone with a comprehensive education when it's needed the most. there is a role for a legislatively established safety net. I work at a rural hospital, and when there is a patient outside the scope of our practice within the trauma system, there is an established safety net for us to move within. Forest General and UMC are the safety net for that patient. And there's a trauma system of care that is part of that, part of the law, because it's the safest plan that protects the public. The physician-led team is there for NPs when their scope is reached, and it should remain that way. If full practice authority is granted, it paves the way for those with an abbreviated education to venture into the most vulnerable populations without a safety net. If full practice authority is granted, then NPs are connected in no way to medical training or medical regulation. Full practice authority allows those that choose it to sever ties completely with the Board of Medicine and to proceed unregulated. And if something were to happen, a missed diagnosis or a medical error, the case would go to the nursing board for regulation. Nursing boards do not have authority over the practice of medicine. For those of you in the room that have voters in rural and underserved areas, I ask that you consider this outcome if the law is changed from the current system. All Mississippians deserve a physician-led team to provide that safety net of care. The third take-home point that I would like for you to remember has to do with quality and cost of care. Today, we've been presented with quality and cost of care data on NPs, and that it is equal to physician care. And I also have a stack of articles, all peer-reviewed, all published, that aim to prove our position. They show that NPs have low quality outcomes in various areas such as opiate use, appropriate ordering of radiology, diagnosing serious conditions, utilization, and cost of care. I have a copy of them today if you would like to read them or discuss them outside of this hearing. But I'm not going to take your time to go through each one of these or provide a summary. I found that in cases like this, where you have two sides of the debate, both with a lot of data, it's best to reevaluate the entire problem by putting the patient first. So we will look at up-to-date data from our population here in Mississippi. Quality and cost of care data is critical to consider, but it's essential to look at data for our state. We should look at quality of care comparisons for our population because we are, in general, sicker and more vulnerable than the rest of the United States. We should look at cost of care data for the same reasons. It's more complex than who costs less to hire. It's imperative that you have data to carefully consider the impact of this legislation on providing care in Mississippi. This affects your bottom line. Last week, I had the opportunity to meet with physician leaders at Hattiesburg Clinic. They shared with me their experience and claims level data that unequivocally supports the physician-led team. And I have their permission to share their results here. Hattiesburg Clinic is the largest physician-owned multi-specialty clinic in Mississippi. It is one of the largest in the southeastern part of the United States. Hattiesburg Clinic employs 304 physicians, 206 nurse practitioners and physician's assistants, has over 47 specialties in 74 facilities. It's located in 19 counties, and they serve a market of 750,000 Mississippians. This is 25% of Mississippi's population. In 2020, they had 1.1 million clinic visits and over 32,000 outpatient surgeries. About 3 years ago, in line with continuous improvement, Hattiesburg Clinic sought to determine if their model of providing care met quality outcomes and was cost efficient. And at this time, their model for providing care was the following. They had NPs that saw their own patients. They had NPs that shared patients with physicians, and they had physicians that saw their own list of patients. And their expectation was that quality and cost of care was the same among all three cohorts. And as a business, we can imagine that their goal was to show the same. They anticipated following a strategy of many clinics around the US, hire more nurse practitioners, and save some money. Using claim level data, Hattiesburg Clinic decided to compare quality and cost of care for these cohorts. So they looked at 10 years of data with over 300 physicians. And what they found with 300 physicians, 150 nurse practitioners, and what they found was unexpected. Quality metrics for nurse practitioners who saw patients alone did not meet quality metrics for nurse practitioners who saw patients with physicians. It did not match the quality metrics of physicians, and their data is provided here. We look first at quality outcomes. They looked at some of the same outcomes presented in the studies you've already heard, but the data that they found was different. The data from Hattiesburg Clinic showed that nurse practitioners who saw patients alone had lower rates of flu vaccination, pneumonia vaccination, breast and colon cancer screening, cholesterol, A1C, and diabetic foot and eye exams. When they examined the number of ER visits for their clinic, the total number of ER visits was higher for nurse practitioners who saw patients alone. When Hattiesburg Clinic looked at the total number of specialty referrals, nurse practitioners made a higher number of specialty referrals. Most remarkable was the cost of care data. When Hattiesburg Clinic examined the cost of care for those nurse practitioners that did not share their patients with a physician, they found that spending was $43 higher per member per month. So they took this number and extrapolated it to their entire patient population. They asked themselves, what if nurse practitioners saw a majority of or all of Hattiesburg Clinic patients? What would be the increase in the cost of care? And at $43 per patient per month, 20,000 patients in 12 months a year, it translated to a difference in cost of $10.3 million. And when the data was risk adjusted for patient complexity, the cost of care difference jumped to $119 million per year. And this was just for the patient population at Hattiesburg Clinic. And we've got to start thinking about how this applies to the whole state. The evidence was enough for Hattiesburg Clinic to completely change their model of how they provide care. Today, physicians and nurse practitioners share patients and they alternate visits, meaning a patient will see a nurse practitioner for one visit and then a physician for the next visit. This decreases cost of care directly by cutting the total number of physician visits in half, but it also ensures quality review of every chart that the nurse practitioner writes. The goal is to decrease the number of specialty referrals, unnecessary testing, and ER visits. This is an innovative approach that is exciting and a remarkable solution, but it's based on clear, up-to-date, claims-level data that in Mississippi, the cost of care is more for nurse practitioners who see patients independently. What's particularly exciting about this data is that it doesn't promote the physician and it doesn't put down the nurse practitioner. It promotes a team. Together, the physician and the nurse practitioner are synergistic in the overall practice model for healthcare in Mississippi. My goal is to give you the data that you need to make the choice to protect Mississippians. with a physician-led safety net of care. The 3 take-home points that are critical to remember is that the educational differences between nurse practitioners and physicians support continuing the physician-led team, that all Mississippians deserve a strong safety net of care with the physician-led team, and that when cost effectiveness and quality of care data is examined specifically for Mississippi, the physician-led team provides the best care. All of this only scratches the surface of the shaky foundation for the request for full practice authority. We do not have time today to dive into nurse practitioners switching specialty without training, nurse practitioners supervised by physicians of a different specialty, regulation of medical error by nurse practitioners, and what other states have experienced having passed full practice authority. Just because 24 other states have done this does not mean that it is right for Mississippi. Mississippi has a unique set of circumstances that require you to consider how each law will affect Mississippians. This has always been true, especially for discussions regarding the health of our population. Outsiders may not understand this, but we do. Voting against full practice authority does not prevent any nurse practitioners from getting a job. It does not stifle the growth of NPs in Mississippi. It does not limit access to care. Voting for full practice authority creates 2 systems of care and removes the safety net for the most vulnerable. This law will not affect individuals in Chicago or DC. This law, if changed, will affect the most vulnerable, where a safety net for our patients is most needed. One of my favorite sayings in hospital accreditation, because it applies to life, is that change equals risk. And I encourage you to consider the risk to patients if the law is changed. The system is not perfect, but it is not broken. Meaningful solutions are possible. I thank you for this opportunity today. My hope was to give you objective evidence that the best plan is to continue with the physician-led team. I hope you are starting to get an idea of why I am concerned. I hope that you're thinking about your voters and how they are going to get the physician-led, team-based care that 98% of them prefer and 100% of them deserve.
If you have time for a question or two. Overwhelmingly, nurse practitioners tell me we don't have a physician-led team in any meaningful sense for those who are in basically standalone clinics. That what we have is this technical term collaboration within the meaning of the statute, which has nothing to do with the word collaboration as it's defined in the dictionary. And they say that we're paying physicians to review our charts, and that's not meaningful collaboration. There may or may not be collaboration going on. So basically, they're saying that the problems that you or described and the concerns you have already are there with the existing system.
Yes, there are challenges with the current system. But the way that the law is written, the expectation of the teamwork is there, and passing full practice authority removes the expectation of teamwork. So there is the hope of having better collaboration and better teamwork because it's written into the law.
You mentioned a provision about patient care or whatever the term is, and you mentioned a date of April 21st, and you said it was removed. Can you elaborate on that?
My understanding is that there was an emergency filing from the Board of Nursing to the Secretary of State on April 16th that removed the requirement for the monitored practice hours. and that was granted. And since that time, it's still in place. And so the monitored practice hours, I think, are the same as the transitional hours that are talked about. Nope, they're different. Okay. So it sounds like there's clarification that can be provided. But there was a removal of monitored practice hours on April 16th.
And how did that happen?
I read it in the news. I didn't.
Okay.
Sorry. I read it in the news. It was my understanding that the Board of Nursing sent it to the, sent a request for that emergency filing to the Secretary of State.
Okay. Questions? Senator Blackwell.
Thank you, Mr. Chairman. Thank you, Doctor, for being here and presenting. In listening to testimony, I don't think there's any debate that physicians go to school a lot longer than nurse practitioners. But tell me, when an individual graduates from medical school, is that the end of their training? No, it's not, is it? They continue to go on some residency programs, and even after that, your life is consumed, I bet, with reading periodicals and learning, collaborating with other colleagues. Am I correct with that?
So yes, our education continues. Collaboration is a word that isn't built into. Sorry, it's a debate. It's a word that's debated, but we collaborate.
You consult
We
then
collaborate.
maybe with
We work together as a
other
team.
colleagues. Is
Yes,
that
we
correct?
definitely work with our colleagues as a team.
And would you agree that's the same thing with nurse practitioners when they get out of their training, that they're continue to learn?
I think that any healthcare professional continues their education for life. It's difficult to say how much collaboration is promoted, since the standards suggest independence explicitly for nurse practitioners.
Right. But they still continue to learn, and
Absolutely.
every case that you see, some cases are, let's say, medically routine, and others are going to be a little bit more complicated in terms of diagnosing and treatment.
Yes.
And that comes through experience, doesn't it?
The challenge is patients don't present with the diagnosis, they present with the chief complaint, and even the most rare conditions could look like a very simple presentation.
Right.
So they're all mixed
But
together.
it takes some time to learn that and to sort it out. Am I correct? All right. So either, regardless if you were a physician or if you're a nurse practitioner, you're still going to have some learning that you're going to be, a learning process that's going to continue throughout your career.
Yes. And
Right.
one of the differences is that it's standardized for physicians and not for nurse practitioners.
Right. So we have 28 other states that have done away with this collaborative relationship. Can you cite any specific cases of malpractice or misdiagnoses or
Betty
in these
Wattenberger.
states? I'm sorry?
Betty Wattenberger in Texas is one that I can give you I can send you the reference for it.
So you got one.
I have others. That's the first one that comes to mind because
Right.
it was a very striking
Are there
case.
any physician malpractice claims?
So yes, there's going to be some for both. And as pointed out earlier, there's 7,000 nurse practitioners and none have been reported for medical malpractice.
So either case, there's a potential for malpractice, regardless of nurse practitioner or physician. Right?
Absolutely.
All right. In these collaborative relationships, you're talking about a physician-led team, but my understanding that through the relationship, these charts are reviewed periodically, once a month, maybe?
So there's two types of collaboration. There's the active and the individual case. So when I work with nurse practitioners in the emergency room, I'm co-located with them. They're physically next to me. And if they have a question, they'll come and ask me. And that happens about 4 to 6 times a shift.
Mhm.
And then there is a retrospective chart review. And I think it's quarterly that a certain number have to be reviewed. And some people may not see value in the retrospective chart review, but retrospective chart review is built into CMS, Leapfrog, and the NHSN.
All right. And that's in a facility where they're working side by side. So the nurse practitioners that have collaborative relationships with physicians who are not in their office, those charts are reviewed. My understanding is about every 30 days or so. So The patient's already been treated and gone. So where's the leading
That's a
by the
great-
physician?
That's a great point. So the physician actually, and I didn't understand this until I started working as a chief quality officer. Retrospective chart review can provide critical information on updating policies and protocols. And so retrospective chart review can help inform a higher standard of care when it's done appropriately.
But it doesn't do anything for that particular patient that's already been seen and
The expectation would be that if it was outside the nurse practitioner's scope, they would reach out.
right. But if there was something that needed to be improved, there'd be a dialogue or discussion about it. So next time a case presented, it might be treated more in lines with the way the physician
Exactly.
had recommended.
And without the retrospective chart review, the opportunity to find that would never have happened.
Right. But my point is, it occurs after the patient has already been
It
treated.
does.
Right. And lastly, this is just a anecdotal comment on something you just said. There's 28 other states that have done away with this collaborative relationship. I'm not aware of anybody going to hell in a handbasket because of it. But your comment is just because they did it doesn't mean we have to do it. To some degree, I understand that. We don't need to rush into anything. But at the same time, in my point of view, it's why we're number 49 and 50, because we have too many people who have that argument about it. It doesn't matter that every other state did it. We're Mississippi and we're not going to do it. So, and you don't have to comment to it, but I understand where you're coming from. But
No.
it just, I think we need to have more of an open mind. The world changes.
Absolutely.
The practice of medicine has certainly changed over a period of time. So
I agree with you 100%. I think there's some unique issues with regard to supply that were brought up that make the nurse practitioner issue in Mississippi very unique. And we can discuss it if we have time.
Senator Parker.
Thank you, Mr. Chairman, and thank you for being here today. I'll say that in coming in this room for many years, over the last 25 years, it doesn't matter who you are, this is a nervous room, and no matter what you do, it always is just one of those things. But what I've kind of learned in coming into this room, no matter who you are, whatever the issue is, I always try to leave here learning something, about one side or the other. And I think that's the purpose of this meeting, is to kind of encourage that today. And you said one thing in the Hattiesburg information that I found interesting, and that was that amongst the nurse practitioners who were seeing patients mainly on their own, that their referral level or the number of referrals that they made to other specialties was higher than in the MD group. And my comment on that would be that I find that as a potential favorable situation in that model instead of an unfavorable one, because in looking at this, because all we have is data to look at on it, and in hearing the malpractice kind of conversation that's going on, I think the fact that we've seen, at least in our state, that amongst the nurse practitioners, the malpractice claims have been low. Would you find that that is an indicator in some degree that proper referrals amongst that group of providers are being made?
So 2 answers. The first, with the referrals, specifically about the referrals for nurse practitioners who see patients alone, it may look favorable, and that's one way to interpret it. Another potential interpretation is that if they had collaborated with their physician, or if the physician had been co-located, that unnecessary referrals would have been decreased, and the answer could have been provided by the physician that they were collaborating with. The second, about the claims or the reporting of nurse practitioners with medical error, it brings up a whole nother question of the reporting culture in Mississippi and reporting of medical error to the boards. Both boards are going to be report driven, right? And so if if there's any, to me, what it does is means that, and this is what I oversee at the hospital, right? So I see reporting, oversee reporting, and when things happen, we've mapped out the process and we've done things to increase reporting. But I think the absence of reporting is not necessarily a positive.
Okay, now, I'll say this because in a lot of your discussion, and this is what I tell people who are thinking about running for legislature, you always consider the lowest common denominator. So, looking at the patient first or looking at the student first, if we're thinking about education is the way to get the best answer. But in our state, what I found in my time serving here is we are a different state. And we are different because unfortunately, even though the Hattiesburg Clinic has done a great job at reaching out to the 19 surrounding counties around there, we still have areas of our state that are not going to have a Hattiesburg Clinic that's going to be able to reach them. And unfortunately too, as we've looked at other data today and we've seen that the number of physicians is going to change over time, and we maybe see that the nurse practitioner number is rising. Do you think there is an opportunity, for doctors and nurse practitioners to work together specifically, to get more people into those critical access areas in some model? And if collaborative or and I'll say this too, as lead up to this, it's probably very easy to get a collaborative physician in a metropolitan area, because that physician probably has a relationship with maybe a nurse practitioner who's very close to them. But if you were collaborating, I would think it would be hard for you to collaborate with someone who is, 26 counties away in a very rural setting and you don't have a relationship with them. But do you see any way that the MDs and the nurse practitioners could work together, to fix this problem, and to ease some of these restrictions other than what's being proposed?
I appreciate you bringing up this topic. With regard to access to care in rural areas, I think that because we have over 6,000 nurse practitioners and the distance restriction has been removed, also telemedicine is going to remove those barriers, but not have to have the physician right next to them into the clinic. The other is that before this presentation, I didn't put it in there, was the Bureau of Labor Statistics and HRSA actually have very robust data to show that Mississippi, compared to other states that have taken up full practice authority, have an abundance of nurse practitioners. We have 2.4. Our state is ranked the highest in the number of nurse practitioners per capita. They use a statistical variable called a location quotient, but it just means how many we have for our population. We have 2.4 times the national average of nurse practitioners. Of the top 10 cities in the entire United States for the per capita nurse practitioners, Mississippi has 3 of them. So our state has a lot of nurse practitioners, and HRSA.
I guess my comment on that would be that I think we probably should, because if we do have a shortage, that gap has to be filled, and were that gap not being filled at this point, and was that data you're presenting not correct, what would be the impact to the quality of care and the access to care? And I would think it would be quite devastating.
So we should, and we have a lot. And the question then is, how many is enough? And if all the barriers have been removed to have nurse practitioners go into rural areas, then why hasn't it been solved? And how many more do we need?
And that's what I think we're still working for here. And then, and I'll just one other little thing I want to ask here, and you may not be aware of this. In the collaborative agreements, there's usually a dollar figure attached to that. And I don't know if you're aware of that.
Yeah.
And what's the highest dollar figure you've heard attached to a collaborative agreement?
So I would like to comment on that, if that's okay.
Sure.
There is a study from nurse practitioners that looked at the total number of nurse practitioners that actually pay out of pocket, and it's only 4% pay out of pocket, according to this national study. 4% pay out of pocket. Now, how that
who's-
applies in
So
Mississippi,
who,
I
in
don't know.
Mississippi, whose pocket are they paying out of if they're not paying out of their own pocket?
I think that it might come through the hospital. I have
Yeah,
the
because
study. I can
you
give
know,
it to
I
you.
would say that, you know, if there's a collaborative agreement with a duty to refer to the collaborating physician, and there's not a fee that's collected on that, I would view that as a kickback. Would you not?
I don't, repeat the question again?
So if there's a collaborative agreement and the physician's only reason to collaborate is not to collect the fee, but if they're just receiving referrals from that, you know,
Oh, I don't.
I mean, that's the
don't
only way
know.
I could see a collaborative agreement,
I've
you know,
not heard
working
that.
without a fee.
I've not heard that argument before. I don't know.
But I have heard, at least in conversations, you know, numbers up in several thousands mentioned, you know, in some of these agreements. And do you think there's a kind of a dot, you know, and let's just, you know, say your model. let's not
Senator
change
Parker, it was
anything.
some time ago, you said you had just one little additional question.
We're having
But-
fun,
so-
but we're having
So
fun.
Senator
The
Brian,
hour is getting
I'm
late.
having fun.
There are other people with questions.
I'm okay.
I have,
I think
I've
there's
been
opp-
here for several years and I have learned from the best on how to utilize my time to the greatest extent possible. So I will finish, you know, just with the follow-up on that. But do you think there should be in the existing model with all seriousness that there should be a top limit
I
to
think
what
there
that
is an
number
opportunity for
could
fair
be?
market value discussions.
Right, and you know, but a top
But
number
that is
does
outside
make
my scope of expertise.
right, but something that is exorbitant just doesn't seem to make sense, correct?
I think that, as I stated before, the system isn't perfect and there are opportunities like this for improvement, but it doesn't require the law to be changed.
And I do thank you for being here and thank you, Chairman, for the indulgence.
Thank you.
Well, I was going to call on Senator McMahon, but he just left.
Now to run them off.
Thank you. Thank you very much. Dr. Brunson.
Good afternoon, Mr. Chairman and members of the committee, and thank you for the opportunity to present reasons to you for why physician-led team care along with collaboration is so important for patient care for all Mississippians. I am Dr. Clark Bronson. I'm the Executive Director of the Mississippi State Medical Association and the Professor Emeritus of Anesthesiology at the University of Mississippi Medical Center. I think most of my work with you over the past several years and your colleagues stems from my 9 years on the Board of Medical Licensure and my more than 30 years at UMMC, where I served as Chair of Anesthesiology and served in the Vice Chancellor's Office as Senior Advisor to the Vice Chancellor for External Affairs and Director of Government Affairs. So we have known each other for some time. Our message to you today is simple. Every Mississippian deserves the highest and safest level of patient care possible, and nothing less. We do not need two systems of healthcare in Mississippi. Yet what is being presented to you to allow full practice authority for nurse practitioners will do just that. Not only that, but what is being requested, as you've heard, is in direct opposition to how healthcare professionals are currently being trained. Again, I trained residents, medical students, nurses for 30 years. That is not how they're being trained today. Team-based care is taught as the standard. And with Mississippi having some of the highest health disparities in the country, physician-led team-based care is critical to moving the needle to a healthier Mississippi with healthier outcomes for Mississippians. Now, you heard earlier this afternoon from Dr. Kemp Rogers just now about the non-standardization of the education and training received by nurse practitioners. And that should not fall on deaf ears. Likewise, the Hattiesburg Clinic's recent study with highlights that you were presented with earlier, it bears out the fact that physician-led team care is best for the patient. When seconds count, when the diagnosis must be correct, when it is your loved one's health care on the line, a physician-led team is critical, collaboration is imperative, and delivering the safest and highest level of patient care is and should remain the gold standard. This body has done yeoman's work over the years, and I've had the opportunity and appreciate it to be able to work with you on it. But you've done a lot of work over the past several years to improve access to high quality and safe healthcare. Your creation of the Mississippi Rural Physician Scholarship Program, your Office of Physician Workforce, and the multiple rural residency training programs it has created that works to train physicians in rural areas, making them more likely to remain and practice in those settings, has been a game changer. All the strong work you've done and continue to do on telehealth and broadband, which makes a physician available anytime and everywhere across the state when consultation and collaboration is needed. We commend you for the foresight and the vision you've shown already to make sure all Mississippians have access to high quality and safe physician-led care. As have you, we have heard the argument made that nurse practitioners have had difficulty locating a collaborating physician and/or the collaborating fee is too high. And you specifically asked us at the Mississippi State Medical Association to work directly with you and to work on a solution to this repeated concern. As you will hear next from our board chair, Dr. Catherine Panel, MSMA has developed a solution to that argument, and we are confident this solution will improve access to care while not compromising the standard of care for all Mississippians. It is indeed a Mississippi solution for Mississippians' healthcare. It will also provide a pathway to engage more nurse practitioners to join the physician-led healthcare team to deliver quality healthcare in our state. In closing, thank you again for your leadership and the service you do to improving healthcare in Mississippi. We strongly believe that every Mississippian deserves only the best and safest level of patient care possible, delivered by a physician-led healthcare team. I would now like to introduce the chair of our MSMA Board of Trustees, Dr. Catherine Panel, to share her perspective on why collaboration is critical to the safe patient care and more about an exciting program to further improve access to care for all Mississippians. Thank you.
Thank you. Dr. Pennell.
Thank you, Dr. Brunson. Thank you, Chairman Bryan, and the members of this committee for having me today. My name is Catherine Panel. I'm a psychiatrist and I specialize in geriatric psychiatry. I practice in Oxford and Madison. I'm also the medical director of Right Track Medical Group, which consists of 10 physician-led mental health clinics in the state of Mississippi and 1 in Alabama. Again, I also serve as the chair of the Board of Trustees for the Mississippi State Medical Association. Dr. Camp Rogers did an excellent job of showing and pointing out the differences in education between physicians and nurse practitioners. The differences they're not opinion, they're factual and can't be disputed. But what I want to make sure that I relay and emphasize is that physicians value nurse practitioners. We value the vital role that they play in the team. The team approach to patient care works, and it works very well. As I said, Right Track is a physician-led company. I cannot physically see every patient in Mississippi, and were I to try, the wait times to get an appointment would be far too long. I collaborate with 2 excellent nurse practitioners. We have a great team and we enjoy working together. I review the initial assessment and plan on every single patient that they see. I then give feedback where needed. I'm always available to them via phone. I'm also in clinic with them, with each nurse practitioner a day a week, so they can actually walk out of the patient's room and come speak to me about concerns or issues that they're having with the current patient. The patients really like this model too, because they know that the physician is following them and that the physician has been consulted in their care. If the nurse practitioner has a difficult time with the patient and no longer feels comfortable taking care of that patient, I'm always happy to put them on my schedule. If a patient requests a physician to take care of them and wants to see a physician, I'll put them on my schedule as well. The patients enjoy this approach because they know that physicians are following their care. I've had my nurse practitioner stop an appointment, come to me during that appointment and ask for my advice. Patients feel comforted knowing that they have discussed this case with the physician. Physicians want the best for patients, and that is through the collaborative team model. I want to emphasize again that physicians value nurse practitioners. We want to work with them. We've been listening to their concerns, and we've begun to address them so that they can have the best experience being part of the team. But more importantly, we can continue to give the best quality care to Mississippians. One of the arguments that nurse practitioners have posed is the inability to find a supervising physician. I also want to clarify from earlier that when it was said that the mileage requirements is a hindrance into finding a supervising physician. The Board of Medical Licensure has already stepped in and helped with that by removing this mileage requirement. As long as you have an electronic health record that allows the supervising physician to review records and a Mississippi license, he or she can be located anywhere in Mississippi. But nurse practitioners still express difficulty in finding a supervising physician. As Dr. Brunson stated, the leadership of this body asked us to find a solution, and we have responded to your directive and have created a solution. We have partnered with a company known as Collaborating Docs to form Collab Mississippi. Launched at 1:15 today, Collab Mississippi is a program that matches nurse practitioners with supervising physicians. They guarantee a match with a supervising physician within 30 days, but most of these matches occur within 1 week. They will enter into a 1-year contract with a 30-day out in case that this partnership is not working. Collaborating Docs also provides comprehensive insurance coverage for the collaborative relationship, so separate malpractice coverage is not required. Still, another argument that nurse practitioners have made is that supervising physicians are charging too much to supervise. First, I've yet to see any concrete evidence of this, but regardless, again, physicians are listening. Physicians don't enter into these agreements to make money, but to provide safe, quality patient care. But it does take time to collaborate. I take 1/2 day a week just to review charts and follow up with my nurse practitioners. But we again responded to that argument with Collab Mississippi. The fees are based on fair market rates. The estimated fee schedule from Collaborating Docs shows that the fee could be as little as $500 a month. Collab Mississippi allows us to maintain and improve access to care while maintaining and not compromising the standard of care for all Mississippians. In closing, I'm frustrated, physicians are frustrated, and I know you guys are probably frustrated as well. This scope battle comes up year after year. There are so many ongoing issues in healthcare in Mississippi. These issues need addressing or solving to better the healthcare in Mississippi, like telemedicine, prior authorizations, medication coverage, and so many more. As a psychiatrist, I can see that there are numerous ongoing mental health issues that need to be addressed. However, we're unable to give these issues the attention they deserve or need because the scope battle continues to come up every year. Every Mississippian deserves the best and highest quality of care possible. No Mississippian should expect anything less. Your wife, your husband, son, daughter, grandchildren should only receive the highest and safest level of patient care possible, nothing less. That level of patient care is through the physician-led team. Collaboration is proven, it works, and 98% of Mississippians believe that it's the best way to ensure that Mississippi patients get the care that they need and deserve. Collaboration does not hinder the care nurse practitioners give, it simply enhances it. And Senator Dr. Parker, earlier you also asked about if a case of malpractice were to arise and you went to court and with a nurse practitioner, would they be held to the level of a physician? That is untrue. That in the court of law, when they go in and enter into like a malpractice case, they are only held to the level of a nurse because that is what they are saying that they are practicing. They're not practicing medicine, they're practicing nursing.
Questions? Senator Blackwell.
Thank you, Mr. Chairman. Thank you. This twice I've heard this reference to this 98% of Mississippians want a physician. Like, what was the question that they
Prefer physician-led care.
And I've never seen that survey. Where,
We can get it to you, but it was also done through Mississippi State. It was an actual, go ahead.
Thank you. I can answer that. We did a survey a year and a half or so ago with Mississippi State, their InSpark Center, and commissioned a study with them to ask Mississippians about what they prefer as far as their healthcare, who they prefer to have as head of the healthcare team. Those were the results that came back.
so the wording was, who do you provide, who would you prefer to have leading your healthcare team?
Well, there was a battery of questions at Mississippi State, which in InSpark Center, I think you know them. They're very reputable, nationally known.
Would it be possible for the committee to get a copy of that?
Certainly, we can
survey?
provide you that. I think you find that very interesting.
All right, thank you. And then I had one other question, Doc, about your nurse practitioners. Are they employed by you?
Yes.
Yeah, and to me, that's
I
a
have,
whole,
well, I have two that are employed through my company and one that is not, that's
Right.
in a rural area that I
and
supervise.
to me, under that relationship, I can certainly understand the collaborative and the team leading. And I think what we're focusing on here is those who are not employed, those nurse practitioners who are in independent practice. So, but anyway, thank you both.
If I might, sir, about that, those are the ones that we're actually trying to come up with a solution for those who are practicing in a clinic without a physician, is how do we make it such that the same standard and level of care is possible for them? And we can do that through telemedicine. I mean, you've done a yeoman's job on getting telemedicine. The pandemic has already proven we can make a doctor we can teleport a doctor, so to speak, anywhere to do a consultation and or to see a patient. As you continue with broadband and we get it out across Mississippi, that's how we're going to get physician care with nurse practitioners and PAs across our state. So then we don't have to worry about whether or not there's going to be two standards of care, whether or not we're going to be asking nurse practitioners to go out in areas where patients are the sickest without backup. We know where those sick patients are, and it is, in our mind, unreasonable to put someone who doesn't have medical training out in the area where you're going to have a sicker population of patients. What we're trying to do is figure out a way to get care across our state, maintain the same level of quality and safety, and one standard level of care. Across our country, we have one level of care that's taught, and that should be no matter where you go in our state or across the country, same level of medical care.
Thank you. About 57 years ago, I was in the 7th grade. I have a December birthday. I was either almost 12 or barely 12, as the case may be. And I don't know why, but I was taken with the Dickens' A Christmas Carol, because there was a book which name was A Christmas Carol, and that somehow got my attention. And that led to my deciding it would be well for the class to put on a play of A Christmas Carol. So I adapted A Christmas Carol. So my notion was we would practice this play after school. And so after school was over, we were down there practicing the play. And the principal came by and says to me, he looks in the room and says, "Ha, Brian, what are you doing with a room full of people at 4:30 in the afternoon?" And so here it is, 57 years later, and I'm afraid that someone's going to come knock on the door and ask me what I'm doing with a room full of people at 4:30 in the afternoon. We've gone later than I intended, and things have been somewhat abbreviated, and I apologize if we didn't have more time for more questions and more exchange, but I think we did as good as we could do, given that time was running short. I hope this clearly will not be the last hearing the committee has. It may be during the session when we have the next one. But thank you all for coming. I know that everyone who presented went to trouble to come up with a presentation, had other things to do. We appreciate your time. There are members of the committee who were watching through the magic of YouTube or whatever. And so with the thanks of all of us to those of you who came, thank you very much, and we'll stand adjourned.